Welcome. We're going to wait a few minutes as our participants join. Well, perhaps we will get started with some introductions. Good morning. Hello and welcome to our colleagues in Latin and North America to NANETS Latin American Virtual Regional Conference. We are so excited to be joined by all of the participants from across the globe for this event. My name is Dr. Pamela Coons. I'm an associate professor of medicine at the Yale School of Medicine, and I am this year's NANETS president. And I am thrilled to be here for our first Latin American Regional Conference. This inaugural conference has been in the works and in the planning for more than 3 years and guided by the NANETS Diversity and Membership Committee. I want to thank the successive chairs who continued to shepherd this project through the years of planning. Dr. Camila Jimenez at the University of Texas MD Anderson Cancer Center, who chaired this committee in 2021. Dr. Nimrata Vijayvergia at Fox Chase Cancer Center, who chaired the committee in 2022. And currently Dr. Bryson Katona chairing the Diversity and Membership Committee in 2023. And with the immense support of Dr. Haidira Del Rivero from the National Cancer Institute, who really also helped shepherd this program that you're about to see today. So as you can see, a collective effort from many members of NANETS. This initiative was also heartily approved by the many past presidents, including Dr. Emily Bergsland at UCSF from 2021, Dr. Jonathan Strasberg at the University of South Florida Moffitt Cancer Center, who is the president in 2022 and has my complete support as the current NANETS president. The present program has been developed in collaboration with experts and representatives of 4 different countries in Latin America, including Dr. Juan Manuel O'Connor from the Alexander Fleming Institute in Buenos Aires, Argentina, Dr. Daniel Bulzico from the National Cancer Institute in Rio de Janeiro, Brazil, Dr. Paula Jimenez from the Center for Research and Treatment in Cancer at the Luis Carlos Sarmiento Angulo FCTIC in Bogota, Colombia, and Dr. Alan Burgett from the University of Nuevo León Cancer Center in Monterrey, Mexico. So we are excited to welcome speakers from Argentina, Brazil, Canada, Colombia, Mexico, Puerto Rico, and the United States. And we'll discuss controversial aspects and management of patients with neuroendocrine tumors. I'm also especially excited to welcome Dr. Thor Halfdannersson, who is currently serving as our NANETS Vice President. He is here today to give the keynote address on precision medicine in neuroendocrine tumors. So next slide. So first, some housekeeping items. There will be opportunities throughout the program to address questions from presenters. Please place your questions in the Q&A box, and they will be addressed from there. We also ask that you please type your questions in English if possible. We do have a translation software, which is very exciting, and shortly NANETS staff will enable this translation software, which will allow you to see the speaker's words translated into your language of choice in a text box on your screen. Please follow the prompt on your screen to use the Wordly program if you want to utilize the translation software. And if you have any questions or issues, please be sure to contact the NANETS staff at nanets.net, as we can see here on the screen. With that, now I'd like to give you some information on NANETS. So to those of you here today who are NANETS members, thank you for attending. For many of you who are new to our society, we'd like to share just a little bit about what our society is all about. NANETS has been in existence since 2007, and our mission has been to improve outcomes for patients with NETs through multidisciplinary education, NET-related medical research, and publication of guidelines and the exchange of knowledge. And today's webinar is really just a perfect example of all of these elements of our mission. Next slide, please. In 2016, NANETS implemented a strategic plan which strengthened our infrastructure and communications and helped really to grow a diverse membership. In 2017, we worked to strengthen our structure and communications by existing and expanding on our committees and membership. This growth continued through 2018 and 2019 as we were really ready to get serious about membership engagement and diversity. And then in 2020, as we all know, the world changed and we had to really pivot and adapt to new ways of communicating and disseminating our knowledge. We were forced to really take a hard look at how to advance our mission in this new environment. By 2021, collaboration, member involvement, and mentorship really occupied the majority of our time and energies. And in 2022, we launched our new official journal, Endocrine-Related Cancer, and we finalized our plans for this conference. Next slide, please. This event has truly been a work in progress for some time now, and we could not be more excited for this opportunity to collaborate with professionals throughout Latin and North America. We look forward to expanding our reach, educating more individuals, and growing the multidisciplinary teams who treat NET patients. Learning from each other is critical as we learn how to take better care of our patients and how to advance the field. So please email us with questions or ideas you may have throughout this event and even after. We would really welcome those. So thank you again for coming today. It is really my pleasure to help launch this event. I'd like to now turn it over to Dr. Camilo Jimenez to speak about the LATAM NANETS initiative. Camilo.
Dr. Kunz, thank you very much for the introduction of this very important event. My name is Camilo Jimenez Vasquez, and I am an endocrinologist, professor of endocrine cancer and hormonal disorders at the University of Texas, MD Anderson Cancer Center in Houston, Texas. I started working on the Latin America NANETS initiative more than 3 years ago, initially as the co-chair of the Diversity and Membership Committee, later as the chair, and currently as a member. Together with my diversity and membership colleagues and the unrestricted support of our presidents, Dr. Emily Bursland, Dr. Jonathan Strasberg, and Dr. Pamela Kunz, and with remarkable support of Dr. Yadira del Rivero, who was a member of the executive board, as well as the NANETS staff, and especially the representatives and speakers from Latin America, we have been able to crystallize this initiative, and we are excited that more than 250 people have registered to this program. Ms. Cassandra Clary from the NANETS team designed the Latin American NANETS event theme and background. The background plays to both the connection of medicine and Latin America using elements of the DNA and cell structure for the images and rich warm colors for the color scheme. Ms. Cassandra researched for appropriate colors and found that the basis of the foundations of the Latin American style, history, and tradition is bright, with rich colors that combine in the most harmoniously and inspirational way. Instead of being literal and choosing the most common combinations of pink with green, orange, blue, and burgundy, Ms. Cassandra used other warmer tones that she found in a research article on Latin American interior design. These colors represent how diverse Latin America is. They represent the mountains, the rivers, the valleys, the oceans, the deserts, and more importantly, the origin and richness of the Native American cultures intertwined with Portuguese and Spanish influences. Following the same order of ideas, we suspect that diversity is also reflected in how patients with neuroendocrine tumors present and how their diagnostic and therapeutic approaches are delivered in Latin America. We want to celebrate this implicit diversity that will help us to understand how to better evaluate and treat individuals with neuroendocrine tumor disease worldwide. This initiative is the beginning of a strong relationship between Latin America and the NANETS. With this in mind, We have designed a program in which the speakers from Latin America will present and discuss several interesting cases that will help us understand our similarities and differences, followed by a review on controversial topics in endocrinology, oncology, and surgery in the neuroendocrine world. We are here to learn from each other and to grow together. We are very grateful to the representatives and speakers from Argentina, Dr. Juan Manuel O'Connor, from Brazil, Dr. Mariana Bruno Siqueira, Dr. Rachel Richardman, and Dr. Daniel Bulsico, from Colombia, Dr. Paola Jimenez and Dr. Leonardo Rojas, from Mexico, Dr. Alan Berget Torres, from Puerto Rico, Dr. Sarimar Agosto Salgado, from Canada, Dr. Julie Hallett, and from the United States of America, Dr. Eloisa Soares, Dr. Alexandra Ganji, Dr. Kalisha Clarkey, Dr. Jennifer Chen, Dr. Nina Vijay Verja, Dr. Shagupta Shaheen, Dr. Thor Aldanarson, and Dr. Daniel Anaya, with what I believe are the most beautiful words in Portuguese, Spanish, and English languages. I simply say, obrigado, gracias, and thank you for making this possible. And let's start. Thank you.
Thank you, Dr. Jimenez. I'm excited to get us started with our first session of the day, Controversies in Medical Therapy, Well-Differentiated Neuroendocrine Tumor. My name is Dr. Shagufta Shaheen. I'm a clinical assistant professor in medicine and oncology at Stanford Medicine, and it's my pleasure to moderate this session. Let me introduce the speakers. Doing a small intestinal case, carcinoid syndrome, we have Dr. Rachel Simeos Pimenta Rachelman, Head Clinical Oncology Department, AC Carmego Cancer Center, Brazil, President, Brazilian Gastrointestinal Tumor Group, Chair, GI Latin American Oncology Group, and Scientific Education Committee member to ESMO, NANETS, and SLAG. Presenting with her, we have Dr. Mariana Bruno Siqueira, Medical Oncology at Institution de Pesquisa and Sino in Rio de Janeiro, Brazil, and member of Gastrointestinal Malignancy Committee of the Brazilian Society of Clinical Oncology. Next, we have presenting on thoracic NETs, Dr. Paulo Jimenez, Professor of Clinical Oncology, Head of the Section of Neuroendocrine Tumor in the Department of Gastrointestinal Medical Oncology at the Center of Treatment and Research on Cancer, Luis Carlos Cemento, Anguilla, Bogota, Colombia. Accompanied will be Dr. Leonardo Rojas, Professor of Endocrinology, Diabetes, Metabolism, and Oncological Endocrinology, Master on Molecular Oncology, Section of Endocrinology at Javerian University, Bogota, Colombia. Lastly, we have a presentation on the management of functional NETs by Dr. Daniel Bulsico, leader of the endocrine chapter of the Brazilian Neuroendocrine Tumor Expert Working Group, Section of Oncological Endocrinology, Section of Nuclear Medicine Radiopharmaceutical Therapies for Neuroendocrine Tumors at the Brazilian National Cancer Institute, Rio de Janeiro, Brazil. Following the presentation, we'll take questions placed in the Q&A box. With that said, let's get started.
Hello, hi.
Hello, good morning.
Hi, everyone. I'm going to share my screen. Just a minute. Can you see, Rachel?
Yes, perfectly.
So, we are going to discuss a case, a challenge case of carcinoid syndrome, and I'm going to present a case of my private practice in Brazil, and Rachel is going to discuss the case. So it's a 59-year-old male. He's a farmer. He's married with 3 children. Of comorbidities, he has hypertension and type 2 diabetes. In follow-up with endocrinologist, he's a daily beer drinker. He has a history of mild diarrhea for 7 years and flush for 1 year. The attending physician requests for him an routine abdominal ultrasound that he performed in March 22. It shows hypervasculated nodules in the liver, multiple nodules in the liver, the largest one with 3.8 centimeters. He then performed an MRI that shows a lesion in the ileum and the mesentery, multiple liver implants, and an enlarged inguinal lymph node. He then asked for a liver biopsy, and it confirms a NANETS G1 with a Ki-67 of 2%. He then was referred to me, and I asked for a PET gallium. And these are the images of the PET gallium. He had multiple liver mets with enhancement of the gallium, and a lesion at the ileum, and a retraction of the mesenteric fat, and the inguinal lymph node also had an enhancement of the gallium. He had the urinary 5-HIAA, it was 65 milligrams. He performed an echocardiogram with normal heart valves, and then we started lanreotide every 28 days. At this time, the symptoms of he had diarrhea and then flush. He had partial symptoms control, and then I asked him to see a surgeon, and the surgeon decided to perform the primary resection. So he had performed a primary resection surgery, and he had multiple post-op complications, gastroparesis, adhesions, and he had to approach a new, he had to undergo a new surgical approach in August for lysis of adhesions, and because of that, he stayed 2 months without taking the lanreotide injections. And at this time, he had lost 20 kilograms, and he weight loss of 20 kilograms since the diagnosis. He had worse from the diarrhea, more than 10 episodes a day. And initially, we thought it was because of the resection of the bowel. But then we started wondering if he was progressing disease. So I asked for a PET gallium and another urinary 5-HIAA that was more than above 75 milligrams. And this is the PET gallium images. These are the PET gallium images. And there was a more, the lesion, there were no new lesions, but the lesions were more enhancement. The enhancement was were biggest, and the lesions were more enlarged in the liver, and the lymph node was stable, and he has no more the disease from the mesentery and the ileum at this time. So I have some questions to discuss with Rachel, and I would like her to lead this. So you prefer for me to ask the questions?
Yeah, you can. There's a question from the audience before we go from there. So someone is asking, what type of surgery did the patient have? So I think it was not clear.
He had a partial enterectomy with resection of the mesenteric fat.
So he had a resection of the primary tumor.
The primary tumor, yes. So the first question that I have to you, Rachel, is about this. In tumors of the small intestine, should we always recommend resection of the primary tumor, even in the absence of symptoms? What do you think about that?
I think when symptoms are there, that's an easy answer, right? But when patients are completely asymptomatic, I think this is more tricky. And it really depends on several factors. So if the tumor is big, so let's say it's 2 to 3 centimeters at least, if there are all the lymph nodes around, if the tumor is functioning, so in your case, the patient has carcinoid syndrome and has a high 5-HAA level. So even if the patient was asymptomatic in terms of the primary tumor, I agree with you, I would recommend surgery, because this prolonged exposure of high level of serotonin may lead to local complications in terms of fibrosis, bowel obstructions, and a lot of complications locally. So I agree, I would have recommended to this patient. I think many of these cases should be discussed, if possible, in multidisciplinary tumor boards. I don't think all patients with asymptomatic primary small bowel NANETS should be resected, but I think we have to take into account if the tumor is functioning, the size of the tumor, and of course, how is the overall clinical condition of the patient. If it's a small lesion and more bulky disease in the liver, then maybe we should prioritize the liver first. But overall, I think, I mean, in your case, I completely agree that you should have been resected. One thing that I would like to, then maybe we can discuss with the surgeons afterwards, is that in many cases, patients with carcinoid syndrome, well, they present diarrhea, they receive somatostatin analogs that may lead to, exocrine pancreatic insufficiency in about 20% of the cases, so diarrhea again. And then we resect the primary tumor, we perform an enterectomy, and the patient may get worsening of the diarrhea. And then many surgeons recommend to perform a prophylactic cholecystectomy together with a partial enterectomy. Probably this is more to decrease the risk of patients who are going to receive somatostatin analogs for a long time, to prevent gallstones complications. But I would say that in my experience, a lot of patients that are not operated for the primary tumor, do not have a cholecystectomy, and receive somatostatin analogs for a long time, many of them never have gallstones. So I don't think it's mandatory to perform prophylactic cholecystectomy in all patients, because it is certainly an additional factor for controlling diarrhea, and sometimes it's difficult to know if it's just the syndrome that is worsening or if it's just all these issues together.
Okay. And what about the dosage of 5-HIAA? Should we aim for a normal value, or would symptom control be the best parameter to assess carcinoid syndrome control? And how often do you dose 5-HIAA in patients with carcinoid syndrome? What do you think about that?
Great questions and very difficult ones. So there's just a question from one of the participants, Kathy Van Dilo. Hi, Kathy. She's asking if the patient had carcinoid syndrome, and yes, the patient had not only diarrhea but also flushing. And there's another question from John Strasberg. Hi, John. He's asking if this patient had a right hematocolectomy and post-op diarrhea, need to think of bile acid, sequestrant like cholestyramine for the diarrhea. That's true. But I think in this case, John, because the patient had an increase in his 5-HAA, it was assumed that the patient had at least a biochemical progression, not radiological progression, but at least biochemical progression. So I would like to hear from people, that you can put it in the chat. Should we aim for a normal value of 5-HAA? I think the more we know that elevation of serotonin leads to this fibrotic complications, including a carcinoid heart disease, which is so difficult to treat. I think we should aim for the lowest possible value. I recognize that it's not always the case that we can reach this. I know that people who have access to telotristat ethyl have had good experiences with normalizing 5-HAA. We don't have that available in Brazil, and I think we don't have that available in any Latin country. So we have to deal with the somatostatin analogs, PRT, and everolimus, liver-directed therapy, and etc. But I think we should aim for the lowest possible value. And how often? I tend to perform the 5-HA every time I ask for a CT scan, so every 6 months for most patients.
Okay.
Unless for patients, I have patients, with disease control for more than 10, 12, 15 years, then of course, then I can increase the intervals. But overall, at least in the beginning, every 6 months.
And what's your preference in terms of follow-up with the imaging exams, MRI, CT scans, and how often do you indicate? I'm sorry.
I tend to order conventional image every 6 months for these patients, for small bowel NANETS with carcinoid syndrome. For the gallium PET, I tend to do it annually, mostly to evaluate if there are new lesions or bone lesions. PET gallium is not a good imaging test to evaluate progression in terms of increase in SUV and etc. Unless you really see new lesions. And in Brazil, we also have issues with access. So many patients have to pay out of their pocket, and it's quite expensive. It is about $1,500 at least in São Paulo. So if it's not covered and patients have to pay, it's even harder to get. But I would say annually, it's good. If there's any suspicion that of radiological biochemical progression, or if you're planning to do PRT, then of course you can anticipate and do a PET gallium before this interval. And there are just 2 questions here. So someone unnamed says, could you comment, when do you consider LAN or octreotide for treatment of functioning and non-functioning tumors? Would you like to answer this, Mary? Marian?
I can answer.
Okay, you want to comment? Or me?
No, we can comment first.
Okay. Well, we know that both lanreotide and octreotide have not been compared head-to-head, but they are considered to be equally effective in terms of tumor control and biochemical symptom control. Overall, in Brazil, lanreotide is half the price of octreotide, so it's more often used by the healthcare providers. But in my experience and my practice, I tend to decide by one or the other based on side effects. So lanreotide tends to offer more diarrhea, more steatorrhea here. So if I have an obese patient, for example, would be, if I can do it intramuscularly, I would prefer octreotide. So for patients who are, for example, had a primary resection of the primary tumor, a prophylactic cholecystectomy, where diarrhea it's going to be an issue, then I prefer octreotide because it leads to less steatorrhea. But this is more on the adverse event profile in my perception. In terms of efficacy, I don't think there is any difference. And then there's a question by Keith Uziskin. Thank you, Keith. If we can get plasma serotonin. We have plasma serotonin, but most of the time we order the 24-hour urinary 5-HA because it's covered, and I think it's more reliable in terms of having the whole day of value.
And if we tend to switch somatostatin analog with initial poor response, if you switch lanreotide to octreotide.
I think we can switch if there are administration issues. So again, if we have a very obese patient who is not, the intramuscular injection is not getting to the muscle, then we can switch to lanreotide. But in terms of poor response and tumor poor response, then I don't think we have good evidence to switch somatostatin analog based on that. Let's say there's radiological progression, like in your case with biochemical progression, switching somatostatin analogs are not very effective.
I don't think it's an option as well.
No.
I just switch when there is adverse events. So I'm going okay. Another question. Would dietary change help to control the syndrome symptoms? Do you recommend routinely tryptophan-poor diets? Do you think it's...
For patients who are not well controlled, I recommend them at least to stop taking alcohol, but I wouldn't recommend them to not eating, bananas or pineapples.
Yes, I have a patient that I eat banana every day, please.
Me too. I eat them too. But I think alcohol, it really triggers carcinoid symptoms, especially in those patients who are not very well controlled. So I recommend them to avoid it. So it's very hard to say to tell to a Brazilian not to eat bananas.
Yes. And this patient, he has depressive symptoms since diagnosis. Would you be cautious in indicate treatment with serotonin reuptake inhibitors? What do you think about that?
This is a very good question, Marianne. And there's maybe 7, 8 years ago, there was this retrospective analysis published in the Annals of Oncology asking that question, if there was any worsening of carcinoid symptoms or in the 5-HAA in the 24-hour urine, with comparing patients who were taking serotonin reuptake inhibitors or not. Apparently it's not. I mean, these drugs, they function mostly in the central nervous system, so it doesn't seem to be an issue in terms of carcinoid symptoms. But we should be aware that the use of certain drugs, including serotonin reuptake inhibitors, increase 24-hour 5-HAA. So usually patients who are taking them, I would say 5-HAA goes up to 12 or 15. Here and the upper normal level is about 9. So we just have to be aware of that. And for patients who are, maybe they have non-functioning tumors, but if they are taking some drugs, the 5-HAA may be slightly elevated, and we have to take this into account. There are some questions here from the audience. Gabriela Werba. Hola, Gabriela. She's saying, I don't know details of the scan, but was the patient assessed for liver metastasis resection?
Not yet. He just resected the primary.
But he had lymph nodes everywhere, right?
No, just one lymph node, just one inguinal lymph nodes. And now he has liver disease and this inguinal lymph node. And it's the next question. It's how do you treat him now? How would you treat him now?
What I find is very nice about your case is that you could capture that the patient has mild carcinoid symptoms for 7 years. So it is a slow-growing disease. It is not in the category of very aggressive carcinoid syndrome. But on the other hand, his 24-hour 5-HAA is quite high, 75. So he is probably at risk of developing carcinoid heart disease. So for that, I would probably, and he didn't respond very well to somatostatin analogs. For that, I would treat him more aggressively, not because of his tumor growth pace, but mostly because of his functioning aspects. So I would probably, I'm not sure how long, he stayed like 2 months without any somatostatin analog. I'm not sure if that was the case of his worsening. So I could still try at least with an increased dose. We have the in terms of radiological control, we have the control arm of NATO-1, we have Clarinet Forte. They're both trials that reinforce the use of increased dose of somatostatin analogs. So I could try that, but I assume he probably will need lutetium-177 as the next step, I think.
Yeah, would you perform some liver direct therapy?
Yeah, we could. His predominant site of disease is the liver, so this is another very effective option. The only thing here is that the patient he has an uncontrolled carcinoid syndrome, so we really have to be careful. The patient has to be admitted to hospital and receive, an intensification of the somatostatin analogs with the use of the short-acting ones. Let's say 24 hours, 1 to 2 days before the procedure, during the procedure, and until the patient is stable to be hospital discharged. So liver-direct therapies are very effective in this regard, but we really have to remember that these patients, they may trigger a carcinoid crisis if they are not really covered for intensification of the somatostatin analog therapy.
Okay.
Do you want to read the question if you want to?
I have some questions at the Q&A.
From Alejandro Roman.
I think we have already answered.
Yeah, we discussed this. And if we have telotristat, unfortunately, we don't. There was even a discussion here. I had a personal discussion with Ipsen at that time, and they decided that they were not going to submit telotristat for approval in Brazil. I don't know what was the reason, but so we don't have the drug here.
I think our time is we're getting out of time. So that's all. It's the NANETS guideline for guidance for carcinoid syndrome, and he had mild or moderate symptom burden, and the recommendation of NANETS is dose escalation, as we've already said, dose escalation of the analog, and perform OPRT or any local region therapy for the booking. And what we did, we changed the nucleotide to every 14 days, like Clarinet Forte, and he had an improvement in diarrhea, and he has no flushing at this time. He has some sporadic episodes of night fever, and I have screened him for infection, and that it was negative. I assume it could be because of the liver disease. And he has stable disease on CT scans in January. And now we are evaluating him for a TACE procedure.
And you don't have the urinary 5-HA, do you?
No.
Not yet.
I've already asked him for that. I don't have the result yet because it was in January.
I think if it really goes down, you probably can save TACE for later. But if it hasn't gone down, I agree, I would add liver-directed therapy. Okay, time to transition to next talk. We're finished.
Great. Thank you so much, Dr. Rachel Main and Dr. Sequeira, for the wonderful discussion. Yeah. Next, speaking on thoracic NETs, we have Dr. Vasquez and Dr. Rojas. Please take the floor.
Thank you, Dr. Shaheen. It's wonderful to join you all in this symposium. I'm going to share our screen. Are you looking well? So our patient is a 30-year-old man who in January 2021 presented to the ER with a hypertensive crisis where they documented hypokalemia and hyperglycemia. He was studied on losartan, prazosin, metoprolol, spironolactone, and metformin. In July 2021, 6 months after there, he came again to the new hypertensive crisis to the ER with general symptoms, muscle weakness, heart palpitations, so he was referred to our hospital. He had lost at least 18 pounds of weight for the last 6 months. At the physical examination, he had a Cushing's phenotype, including purpuric macular skin lesions and stretch marks in the abdomen and groin. The general blood test showed high glycated hemoglobin, high glucose, hypokalemia, and hyperglycemia with normal kidney function. He was studied on IV fluids, including potassium, medications to control the blood pressure, and also he received insulin. The response to the treatment was wonderful, and he controlled all the parameters relatively quickly. These are the hormonal tests that was taken to the patient, where we can see the normal IGF-1, normal prolactin, normal levels of plasma methanephrines, and hypercalcemia diagnosing primary hyperparathyroidism. Also, he had a normal aldosterone and renin levels. The only parameters that continue high was the high calcium of the primary hyperparathyroidism. Respecting upon the Cushing's syndrome, we had some tests where we can see a normal cortisol in the morning. We didn't suppress after dexamethasone at least 9 times the urinary cortisol levels above normal, and also high levels of ACTH. There was concluded an ACTH-dependent Cushing's syndrome. The chromogranin levels in plasma were at least 9 times above normal. This slide is to remember us the etiologies of Cushing's syndrome, where we can see at the right the ACTH-independent causes of Cushing's syndrome coming from the adrenal origin, and the last vast majority ACTH-dependent coming from the pituitary adenoma, but don't forget about the ectopic secretion of ACTH causing Cushing's syndrome. The ectopic Cushing's syndrome can come mostly from neuroendocrine tumors of the as small cell lung cancer, or bronchial tumor neuroendocrine tumors, but also from pancreatic pheochromocytomas, and here we can see the thymic carcinoids producing ACTH-dependent ectopic Cushing's syndrome. Don't forget about that medullary thyroid carcinoma can also cause Cushing's syndrome. So we was done a CT scan of the thorax, where we can see a prevascular mediastinal mass of 78 millimeters with big lymph nodes, and also we could see a lesion in the left adrenal gland. With that, it was done a percutaneous biopsy who showed a low-grade neuroendocrine tumor grade 2 with 1 mitosis and a Ki-67 of 15%. The immunohistochemistry was positive for synaptophysin, chromogranin A, and cytokeratins. So we made a technetium uptake octreotide that showed very high overexpression of somatostatin receptors in the mass, in the mediastinal mass, and also in the pancreas. With that, the patient was started on octreotide monthly. Other images that were done was an abdomen MRI that showed a left adrenal gland with a lesion of 22 millimeters. Also, a lesion in the insonate process of the pancreas, about 17 millimeters within the pancreatic endoscopic ultrasonography. The biopsy of this lesion was negative for malignancy. MRI of the sella turcica showed a 4 millimeter pituitary microadenoma, and the parathyroid scan with the SPECT-CT showed, as we can see in the image, a lower right adenoma and probably a lower left parathyroid adenoma. So the patient underwent an open biopsy and resection of the mediastinal tumor and the mediastinal lymph nodes plus pericardiotomy in August 2021 with an R1 resection. The pathology showed a large cell neuroendocrine carcinoma with mitotic index more than 12 mitosis and a Ki-67 of 40%. The tumor had a diameter of 10 centimeters with necrosis present, microscopic invasion in the perithymic adipose tissue, and compromise of the tumor in the section margins. 8 out of 8 lymph nodes had tumor involvement and extracapsular extension. The immunohistochemistry showed positively for cytokeratins, synaptophysin, chromogranin A, and ACTH. This slide from the new classification proposed by the WHO in 2021 for neuroendocrine tumors showed the classification of lung and thymus in 2 groups. First of all, the well-differentiated neuroendocrine tumors, typical and atypical, and the high proliferation indices carcinoid tumors, and on the other side, the poorly differentiated neuroendocrine carcinoma, a small cell and large cell neuroendocrine carcinoma, where there is virtually always necrosis and high proliferation indices. With this diagnosis of thymic large cell neuroendocrine carcinoma, treatment was initiated with chemotherapy based on platinum, and in March 2021, it was done a fractionated mediastinal radiotherapy to the field. This slide shows what was the follow-up of the lab test for cortisol causing the Cushing's disease, and you can see where they started with the Cushing's syndrome, how they dropped after surgery, and it remained free of disease after surgery and after chemo and radiotherapy, being free of disease for the last year. Also, the chromogranin A levels dropped to normal and maintained in the normal range. It was done, the genetic study that showed a mutation in the MEN1 gene that was conclusive and was supporting the clinical suspicion of multiple endocrine neoplasia type 1 as an autosomal dominant disease. In these patients, he had some components, almost all, of the MEN1 syndrome. He is then in this case, and we have here to say that one brother of him by now has also primary hyperparathyroidism. In this patient, so he has Cushing's syndrome coming from an ectopic secretion of his thymus large cell neuroendocrine carcinoma, also a pituitary microadenoma non-functional, a left adrenal nodule of 22 millimeters non-functional, and pancreatic cyst of 17 millimeters with benign microscopic cytology. All these lesions could cause the elevation of cortisol, and in this case, it came from the thymus carcinoma. And he also has primary hyperparathyroidism. This old slide reminds us the percentage of endocrine tumors, where the most frequent are the parathyroid hyperplasia or tumors, but also we can see that thymic and lung tumor neuroendocrine tumors can account for at least 10% of tumors of the endocrine in MEN1. As a summary, the patient after the biopsy was started on octreotide. He underwent surgery. After that, he received chemotherapy based on platinum, and that he came with the medicinal radiotherapy. And after that, he is on follow-up, active follow-up with images in September 2021, December 2021, and March 2022, with no changes and also no relapse of the Cushing's syndrome.
Sorry because of that. Now, I would like to discuss some topics about this case. In general, the largest reported series of thymic neuroendocrine tumors consists of 160 patients who were reported to the CR database over a 33-year period. 5% of all anterior mediastinal mass and 2% of all neuroendocrine tumors. Really is a rare disease. High-grade tumors has not found as often, and large-cell neuroendocrine carcinomas accounts for 12 to 26% of all neuroendocrine tumors of the thymus, with a median age at presentation around 50 years. Unfortunately, most of these patients have a very poor prognosis when they are diagnosed because they have an advanced stage of the disease. 15% of them were ectopic ACTH syndrome as our patient, and more than 25% of all neuroendocrine tumors of the thymus arise in patients with MEN1. About the treatment that we offer to our patient, surgery is the best option, and the type of the resection is considered a prognosis factor in the literature. Unfortunately, we could perform a ER1 resection. That means a poor prognosis with high risk of recurrence for him. On the other hand, we don't have randomized trials to try to define the best postoperative strategy in this kind of patients. For typical and atypical neuroendocrine tumors of the thymus, incompletely resected, adjuvant radiotherapy is recommended by or based on some international clinical guidelines. For poorly differentiated neuroendocrine carcinomas, even though completely resected, chemotherapy based on cisplatin for 4 cycles as our patient with or without radiotherapy is recommended as we use for small cell lung cancer and based on some international clinical guidelines too. Finally, I would like to discuss some possible treatments for a future recurrence in these patients. For mono or oligometastatic disease, metastasectomy maybe is the best option with or without adjuvant treatment. I don't know, because I think it's a very interesting discussion in a multidisciplinary group. For unresectable disease, rechallenge chemotherapy based on cisplatin is a good possibility in this patient because he finished his chemotherapy 1 year ago. About CAPTEM, we have some phase 2 trials, some important phase 2 trials, retrospective reviews, among others, talking about this topic. The efficacy of CAPTEM was mostly investigated in gastroenteropancreatic neuroendocrine tumors, and some evidence suggests the role of this scheme in the treatment of lung and thymic neuroendocrine tumors. Unfortunately, the better described response is in well-differentiated neuroendocrine tumors. Regarding immunotherapy, we have some phase 2 trials with a small group of patients and some methodological problems that describe the use, for example, nivolumab plus ipilimumab in this kind of patients or espartalizumab in this kind of patients. But today, we cannot consider as a standard of care so far. For this reason, I think it's a good idea the use of pembrolizumab in this patient if he has high microsatellite instability because of the diagnostic indication of this medication. And this is our discussion. Thank you so much. I'm going to see the questions, our chat. About the first question about the pathology, and maybe this patient is clinically grade 3 neuroendocrine tumor, ACTH producing. Sorry, it is a possibility, but we performed a central review of the pathology, and they show necrosis and the morphology of the tumor is large cell neuroendocrine carcinoma. I agree with you because we have now a new classification of the OMS about the thymic and lung neuroendocrine tumors, but we try to define the pathology in this case, and is a large cell neuroendocrine carcinoma.
Also, there is a question that says, do you think that because of the pituitary microadenoma, single sample catheterization will be mandatory before thymectomy? Okay, it's a very good question. Thank you very much. We thought at this time that we had at least 4 sources of the cortisol secretion. It could be from the adrenal, but the ACTH ruled out this source. It could be from the pancreas, then, but the cytology was with no malignancy. We had a little or microadenoma pituitary, and also we had a large mass in the mediastinum. After a discussion in the group, he had indication to for the surgery in the thymus. So we decided to, first of all, taking into resect the mass in the thymus, studying somatostatin analogs, and after that, with the pathology, we could come with a new investigation after that. Also, Dr. Roman, or Mike, how are you? Yeah, he says, thank you, beautiful case professors. Paula and Leonardo, are you using observation in small PNETs in MEN1? Are you always performing surgery? We don't have a vast experience with that. We know that without MEN1 syndrome, a little pancreatic net could be taken with observation, but in MEN1, most probably the patient would not be taken into observation, but to surgery. we have to take in account if there is some clinical symptoms or syndromes that could be caused by the pancreatic net. In this case, as he had cortisol secretion, and it would drop with the surgery of the thymus, and also the ACTH, and also the pathology of the pancreas that was normal as a cystic lesion, we maintained him in observation.
Great.
Can I ask?
I think we have another audience question.
So just to ask, when do you consider bilateral adrenalectomy for patients with ectopic Cushing's? Do you have any indication for that?
Thank you, Dr. Jimenez. It's a very good and difficult question. In general, for bilateral adrenalectomy, we worry much more about the possibility of Nelson's syndrome. And also, I think we have to divide it into two categories, where there is a well-differentiated tumor. And first of all, we have to say that the adrenalectomy is only for the case that cortisol is not controlled with all the therapies available, including surgery, radiotherapy, and all the medications. And if this is the case, and the patient has a well-differentiated tumor, probably the adrenalectomy impairs the life expectancy and also the quality of life that we have to take in account. So it would be only the last source or the last treatment to control the cortisol. Where for bad differentiated or high-grade carcinomas, they had a bad prognosis, so the impairment in life expectancy and the quality of life because of their adrenalectomy would not be more than the bad prognosis coming from the bad prognosis of the tumor. So only for well differentiated, I would say that's not a good idea, but only for the high grade carcinomas.
Great case.
Thank you very much.
Yeah, great case, Dr. Vasquez and Dr. Rojas. Thank you so much for this wonderful presentation and sharing this rare case with us. Next, we have Dr. Daniel Bulzoco, who will talk about management of functional neuroendocrine tumors. Take it away, Dr. Bulzoco.
Well, good morning and good afternoon to everybody. First of all, I would like to congratulate former President Jonathan Strasberg and President Kantz for this initiative. We're discovering that we have so much in common and so much to grow together. I would like to thank Professor Camilo Jimenez for his enthusiasm and for making this happen. And lastly, to all the NANETS staff for all this support. So the topic of my presentation are the management of functional NETs. These are my disclosures. And let's start with a real case. Well, this case was referred to me in 2019. It was a case of a man, a four-year-old physician. 10 years before that consultation, he had a history of bariatric surgery. At that occasion, he had a weight of 166 kilos. He had no comorbidities, no regular medication in use. Well, since bariatric surgery, he presented sporadic dumping symptoms with occasional mild hypoglycemia. And this hypoglycemia became worse in the past 6 months. that this led to a car accident due to a severe hyperglycemia event while driving. He went to the emergency room and had an abdominal CT scan. Well, they found a single nodular pancreatic lesion that after an MRI, the impression was of a suggestive pancreatic net. Well, he had a Dotato PET that revealed a high uptake in this lesion. He was submitted to a partial pancreatectomy, unfortunately with no prior endocrine or hormonal investigation. Well, the pathology was of a non-invasive 1.5 centimeter well differentiated pancreatic net, G2. Well, his question was, did I have an insulinoma? And I answered him probably, but we can say it now. Why? I'll tell you in a few moments. Well, just as all PNETs, the functional PNETs derive from the endocrine pancreas, all of them from the isolate of Langerhans that represent 1 or 2% of all the pancreas volume. But despite this small size, it receives up to 15% of the organ's blood flow. Well, the well-differentiated PNETs are mostly differentiated, as I just said, and they account for up to 30% of all PNETs. They are defined by the syndrome related to its specific and appropriate hormonal secretion. Therefore, it's very important to say that the diagnosis of a functional pancreatic net is confirmed by clinical and hormonal tests and cannot be done by pathology after resection. That is why we can say to this patient that he had an insulinoma after the surgery without no prior investigation. Well, PNETs, as we all know, are very rare. Most of them are non-functioning. And when we talk about the functioning ones, we must say that insulinoma and gastrinoma are the most common. We have the vipoma and glucagonoma that are very rare, and many others that can produce several types of hormones. Let's start with the insulinoma. Well, as I just said, it's the most common functional PNET, and it accounts for up to 20% of them. Luckily, most of them are non-metastatic, but it can be multiple in up to 10% of cases and related to MEN1 in up to 10% also. Its clinical presentation is based on the Whipple's triad, where hypoglycemia lead to both autonomic and neuroglycopenic symptoms. When we say about the biochemical diagnosis, there is no overlap between insulinomas and normal subjects when we find at the same sample a glycemia below 45 milligrams per deciliter, an insulin above 3 microunits per ml, and a peptide C above 0.6 nanograms per ml. Of course, there's sometimes need for a long period fasting provocative test in order to achieve this hyperglycemia level. Once we have the biochemical diagnosis, we need to perform imaging in order to localize this tumor. It is essential to provide best therapy, but not always easy. As I just said, 30% can be very small, smaller than 1 centimeter, and 10% can be mutable. We can use regular traditional radiology strategies such as the 3-phase CT, MRI, but also endoscopic ultrasound, or even the arterial calcium stimulation with venous sampling. There are also intraoperative localizing techniques such as the palpation, intraoperative ultrasound, and the combination of both, leading to a sensitivity to up to 95%. And also we can use nuclear medicine strategy, for example, the Octor scan or PET. The most promising imaging is related to extending 4 the glucagon-like peptide 1 analog, when used, we can use it in SPECT or PET. Unfortunately, we don't have this radio tracer in Brazil. There are two therapy goals that must be reached at the same time when we treat an insulinoma. First, to control hypoglycemic episodes that can be fatal, and also to control tumor burden, especially for those metastatic cases. Well, surgery can do both, and it is feasible in more than 90% of times, because, as I just said, most of cases are localized and non-metastatic. However, if surgery is not possible, we must divide our attention into to control the hypoglycemic episodes. And in this sense, there are different strategies. For example, the use of diazoxide, which is the first-line therapy. It's a drug that has been used for more than 2 decades and has a high level of hypoglycemia control. There are some side effects, but most of them are manageable. The use of somatostatin analogs is also recommended, but it has a low efficacy, as most insulinomas has a low SSTR expression. They express mostly SSTR4, and it can lead to a worsening in hypoglycemia events, as they can block glucagon release. We can also use calcium channel blockade with verapamil, and although glucocorticoids are widely used in this sense, it has a poor hypoglycemia control, and it is limited by side effects we all know very well. In order to control tumor burden, especially for those metastatic cases, we must remember that patients with metastatic insulinomas has a very poor survival rate when we compare to those localized tumors. Maybe because most of these cases are cured by surgery, and we can say whether the metastatic insulinoma leads to death because of the tumor burden of severe hypos. Well, in order to reduce tumor mass, we can use mechanical removal or ablation, for example, debulking surgery. Or we can use palliative radiotherapy or radionuclide therapy, PRRT. There are some very good evidence that it can be useful in order to control tumor burden and the hypoglycemia events rate at the same time. Systemic therapy, conventional therapy, we have several schemes that have been described in order to control insulinomas. And also the use of mTOR inhibitor, everolimus, is interesting. As we can see in this publication, it could reduce hypos in 11 from 12 cases. As we know, everolimus increases insulin resistance in a high level. Let's go to the gastrinoma. It was first described in 1955 by Zollinger and Allison. It is sporadic in 80% of times, and in 20, it is related to MEN1. Up to 80% of them are malignant, and only the minority of them are located in the pancreas. Most of them are located in the duodenum. As most of them are malignant, and the cure chance is very low, below 50% after surgery. Well, the diagnosis is quite tricky, as we must need to prove that the patient has a gastric pH below 2 and a high level of fasting gastrinemia, preferably above 10 times the upper limit. If the fasting serum gastrinemia is elevated but below 10 times the upper limit, we may need stimulation tests. Well, the differential diagnosis for hypergastrinemia is very large. But the most difficult situation is when we have a patient that is symptomatic and in use of a potent gastric acid and secretory agent. Most of the cases are the PPIs. Well, how is the management? Well, once we have the biochemical diagnosis, we start a supplemental workup in order to localize the primary tumor and staging, and also search for if the patient has clinical criteria for genetic tests in order to search for MEN1. Well, we must pay attention in order to start as soon as possible medical symptomatic treatment. It's highly effective in controlling symptoms. Well, once we define that the patient has a localized gastrinoma, surgery with radical intent is the therapy of choice. But if you have an advanced or metastatic disease, then surgery, local regional therapies such as thermoablation, TACE, or PRRT, or systemic therapies are the options for those cases. In terms of the glucagonoma, now it was first described in 1955. It was a case of a pancreatic tumor and dermatitis. In 1971, the necrolytic migratory erythema, NME, was named. Most of cases are malignant with large tumors, larger than 4 centimeters. We must remember that glucagon has a catabolic effect. Therefore, weight loss is a very common clinical finding in these cases. But the diagnosis is based on clinical and history and an elevated fasting plasma glucagon above 500 picograms per ml. Well, the 10-year survivor is of 100% in those non-metastatic cases that was submitted to resection, but it falls to 50% in metastatic cases. So the therapy is surgery for localized tumors and even in resectable mets. The usage of somatostatin analogs is highly recommended because it can reverse the catabolic state and facilitate recovery after surgery. Deep vein thrombosis is very common in patients with glucagonoma. Therefore, we must pay attention in order to the thrombosis prophylactic measures. And if you have an advanced disease, the therapy is similar to non-functional PNETs. The vipoma. VIP effects in the GI tract are several. It stimulates contraction of the enteric smooth muscle cells. It also stimulates secretion of exocrine pancreas, the gastrointestinal blood flow. It inhibits gastric acid secretion, and most vipomas are located in the pancreas, but it can also be found in sympathetic chain tumors such as the neuroblastoma, ganglioneuromas, and pheochromocytomas. Most of them are big lesions, larger than 2 centimeters, and the clinical is of a vipoma is very well known. Patients have a secretory diarrhea, a profuse secretory diarrhea with hypokalemia and metabolic acidosis. It is rarely cured by surgery, but in those localized cases, the 5-year survival is above 90%. Well, the treatment is to correct fluid and electrolyte deficits. We have a very good response in terms of the usage of somatostatin analogs. It can reduce diarrhea in up to 90% of cases. Therefore, we must maintain this therapy despite radiological progression documentation. And the use of PRRT with lutetium can bring symptomatic response in up to 80% of cases. Well, the ectopic Cushing syndrome was already presented by Professor Leonardo and Paula. In this case, we have ectopic ACTH, or even more rarely, a CRH secretion. The prevalence of ectopic syndrome, ectopic Cushing syndrome among a large series of neuroendocrine neoplasia is around 2%. And as they said, most frequent causes of ectopic ACTH secretion are bronchial carcinoids. But also there's some cases we can't find the tumor. There are also rare functional PNETs, such as the somatostatinoma that cause diabetes, steatorrhea, cholelithiasis, and weight loss, and is related to the rare polycythemia, periganglioma, somatostatinoma syndrome. The CCK-OMA, there are very few case reports. It is important to say that it could mimic gastrinomas because CCK peptides are full agonists of gastrin receptor. And there are many others that can produce hyperthalamic, pituitary hormones, PTH, PTH-RP, ghrelin, and many other hormones. Well, the take-home messages from my presentation are, well, functional PNETs account for up to 30% of all PNETs. They can cause a high morbidity because they can bring both hormonal and hormonal syndrome and tumor burden. This clinical syndrome can only be confirmed by appropriate clinical and laboratory workup before surgery. Therefore, appropriate hormonal evaluation must be conducted in accordance with the clinical suspicion, and there is no one-size-fits-all lab evaluation in these cases. Endocrine consultation is recommended in case of a suspected functional PNET, and therapy should aim both hormonal and tumor control. And finally, multidisciplinary team is the key. Well, thank you all for your attention.
Thank you so much, Dr. Bolzico. This was a very informative talk. Thank you for educating us about all the rare scenarios we find can sometimes be challenging to manage. So at this point, we'll open the floor for questions. I am seeing a question from Dr. Jimenez. He is asking, do you offer somatostatin analogs to all functional tumors?
Well, thank you. No, not for all cases. As I said, if surgery is possible and we have a localized disease, it must be attempted. And for those cases in which we have metastatic disease, we must see the peculiarity of each one. For instance, in selenomas, the rate response is very low. But for example, in glucagonomas, it's excellent. So we must individualize.
Do you ever use somatostatin analog in VIPoma?
No, I have the chance. I didn't have the chance.
I think there's a comment and a couple of questions. There's a comment that, Daniel, this is Rachel, and would like to hear your experience. I have seen quite a few cases where upon progression of disease on SSA, the tumor becomes functioning. I think she's seen 3 insulinomas, 1 VIPoma, 2 ACD-producing tumors. I ask if hormone producing can be a type of resistance mechanism to SSA. Obviously, these tumors never respond again to SSA.
Well, thank you, Rachel. Yes, we have seen this situation sometimes where a non-functional NET all of a sudden starts to produce hormone. Mostly, in most cases, it is insulin. And we can say that it is a mechanism of somatostatin analog resistance, but I guess nobody knows very well what happens inside the tumor in order this to happen. But the response rate is very poor for every therapy that we try in these cases.
Next, we have a question from Dr. Coons. Can you comment on the risk of hypoglycemia with SSA in insulomas?
In which scenario?
In insulinomas.
Yes, when we use the somatostatin analog in insulinomas, we must, as I said, we can block also the contra-regulatory secretion of glucagon, and therefore we can provide some kind of worsening in the hypoglycemic episodes. It's not uncommon. Therefore, although there are some reports of the usage of somatostatin analogs in metastatic insulinomas, in practice we avoid it as much as possible. The response rate is very poor, and the risk of worsening hypoglycemia is very high.
Okay, thanks for that input. Next question is, in patients with contraindications to diazoxide with metastatic insulinoma, SSTR positive on PET-CT, would you be using the first line? What would be the first line for you? Analogs plus or minus everolimus?
Well, I guess it depends on the tumor biology. For example, if it is a very well differentiated, I would prefer to start with somatostatin analogs, and it depends also on the tumor burden. If you have a very large, a huge tumor burden, I guess I would prefer the use of everolimus. So I guess it depends on the situation.
Great. In functional insulinomas less than 2 centimeters, not associated with MEN1, do you have experience with ablation as treatment approach?
Yes, apparently there's been some very interesting series regarding localized therapies such as thermoablation or electroporation. It seems quite interesting in these cases, but we don't. I think it's promising, but we're waiting for larger series in this sense.
Great. I think another question from Anna is, does anyone have experience with pasireotide in insulinomas?
I tried once, and so the experience is not very large, but it's interesting as it can have an action on SSTR4. So we expect that the response rate would be better than the traditional long-acting somatostatin analogs.
A few more questions. Another question from Alejandro Roman. Question is, I have a patient with VIPoma. I have used lanreotide, then increased dose with stable disease and partial control of disease. After progression, I use everolimus with partial response and perfect control of diarrhea in combination with lanreotide. Now 9 months of everolimus. Probably, I think it's just a comment.
Well, nice,
Commenting,
very nice,
nice presentation, Dr. Daniel. That was the comment.
Well, thank you, Alejandro. It's nice to hear that. Nice to hear that.
I think we tackled the next question. Is pasireotide effective for insulinoma? I think you already kind of shared your experience. The last question I see is, in our hospital, we have the case of one girl, 17-year-old, and her father was 42-year-old with familial nesidioblastosis, diagnosis in adulthood. Diffuse lesions in pancreas were treated by subtotal pancreatectomy. New mutations were discovered in the DNA exomes testing. Do you know any similar cases?
No, I had one case of an acidoblastosis in a young surgeon. It's interesting because acidoblastosis is a disease from the young, but I have no idea of this linkage between this acidoblastosis cases in her experience. Regarding this case that I presented, there are some interesting issues regarding acidoblastosis after bariatric surgery. And after this case was presented to me, I reached out the pathologists in order to see the surrounding pancreatic tissue around the PNET. And he told me that, well, Daniel, there's a lot of acidoblastosis here. So we can't assume that there is a higher risk of insulinoma after bariatric surgeries. There are some case reports in this sense.
Thank you, Dr. Bolzik. A wonderful discussion. This was a great start to our program. Thank you all. I will now pass it off to Dr. Nina Vijayavargiya for our next section.
So thank you.
Thanks.
Good afternoon, everybody. We will continue what we have been doing, such an amazing start to this amazing conference that we have, and I'm so glad I'm part of it and all of you are here. We're going to continue our discussion and talk about some interesting controversies. Something that's really dear to my heart is high-grade and poorly differentiated cancers. So my name is Nina Vijayavargiya. I am a GI medical oncologist at Fox Chase Cancer Center in Philadelphia, and obviously have a passion for NETs, hence I'm here, and especially for the poorly differentiated and high-grade NETs. So welcome everyone. Here we have very interesting speaker lineup and a very exciting speaker lineup. Next slide, please. So our session speakers today are Dr. Alan Bergette. He is a gastrointestinal medical oncologist and a professor of medicine at the University of Nuevo Leon Cancer Center in Mexico. We are very excited to hear his presentation, but don't go yet. We will then have an amazing talk by Dr. Juan Manuel O'Connor, who is a professor of clinical oncology and the head of gastrointestinal medical oncology at the Alexander Fleming Institute in Argentina, Buenos Aires. We are very excited to have such accomplished and such amazing physicians here giving our talks today. So let's start. We're going to ask Dr. Bergette to take the floor.
Thank you, Dr. Nina Vijayavargiya. It's a great pleasure to be here and to be part of this amazing panel of speakers. So I would like to thank also the scientific committee for the invitation. It has been a great effort during the last 3 years and mostly in the last year to be able to present and to have this this amazing symposium on this disease. So without any further delay, I would like to start with this presentation. This is a clinical case presentation and a small review of the management and to my opinion, one of the most difficult cases in neuroendocrine tumors, which are the grade 3 neuroendocrine tumors. So so this is a case, these are my disclosures. So this is a case of a 52-year-old male. He has no family history of cancer. He has no comorbidities. This is a very fit patient. He likes to exercise. He goes to work every day. He has 2 kids. On February of 2021, he presents to the ER with a history of 2 weeks with diffuse abdominal pain. The initial workup included an abdominal CT, which showed no evidence of acute disease, but it showed multiple bilobar liver lesions suggestive of metastatic disease and a 3-centimeter tumor in the pancreatic body. So his initial CBC and chemistry were actually unremarkable. And and the review of symptoms also was unremarkable. He was, as I said, a very fit patient. Physical exam was relatively normal, only he had slight abdominal pain upon the palpation on the right upper quadrant. And the patient was admitted to the hospital for diagnostic workup. His initial tumor markers, CEA and CA99, were normal. And so the patient underwent a liver biopsy. And three days later, the diagnosis was of a metastatic neuroendocrine carcinoma. And I would like to underline this word, because wording in neuroendocrine tumors is very important, so we can all follow the same directions here. So this is the original report. It's in Spanish, but you can see that 22 mitosis per 10 horsepower fields were presented, and Ka 67 of 35. So, but the diagnosis says neuroendocrine carcinoma. So he later underwent an endoscopic ultrasound and biopsy with the core needle. We have the advantage of having this endoscopic ultrasound with not with fine needle aspiration, but with core needle, which allows us to give better pathologic diagnosis. And later he underwent a PET CT. I'm gonna show the results of the endoscopic ultrasound. This showed a 3.5 centimeter tumor in the body of the pancreas with no vascular involvement, but and the pathology of that biopsy showed a primary neuroendocrine carcinoma, again with this characteristics, but again with the naming. And then because this was considered by the first team that was taking care of the patient, he was considered a neuroendocrine carcinoma. They ordered an FDG 18 PET, which showed a multiple FDG-avid hepatic lesions, with the largest in segment 3 with a measurement of 7.8 centimeters and an SUV max of 7.8. He had no signs of extrahepatic disease, only the lesion in the pancreas, obviously. So so later, this patient was seen by a first oncology team, and he was started with first-line chemotherapy with etoposide and cisplatin. He had the first 3 cycles with actually no toxicity whatsoever, just grade 1 fatigue. But for the rest of it, it was like very well tolerated. So after 3 cycles, the patient underwent a PET CT for response evaluation, and PET CT reported stable disease with criteria for stable disease. And then the patient continued with chemotherapy. The cycle after the 4th cycle, he developed acute kidney injury, so he had to be to delay a little bit his chemotherapy, go to see the nephrologist. Fortunately, this could be controlled without needing of any renal substitution therapy, and so the patient, we had to switch to carboplatin etoposide on the last 2 cycles. And after 6 cycles of chemotherapy, the patient, after 6 cycles, the patient went again for a imaging evaluation with stable disease, with no or minimal toxicity with chemotherapy. So this patient, the best response that the patient achieved with first-line platinum etoposide was stable disease. So the patient was really asymptomatic. This was a non-functional tumor with this patient was offered another 2 cycles of chemotherapy by the initial team, but the patient actually refused that and looked for a second opinion, concerned about the lack of response to the initial scheme of chemotherapy. So as I said, the patient was asymptomatic, and so the other team, what we did was we asked for a pathology review of both biopsies, and the new pathology review, as you can see here, put as an addendum, was that this was a well-differentiated grade 3 neuroendocrine tumor of the pancreas. So with the new classification. So this actually raised a lot of questions for us, because we have a patient that is actually achieving only stable disease with chemotherapy. He has no symptoms whatsoever. So this was a difficult case for us to take. So the patient was ordered a gallium PET CT. So so to see if this was actually an avid tumor that we could treat with analogs. Initial trial, so this was positive, and so an initial trial of lanreotide monthly was offered. So after 4 months of chemotherapy, scans were made with stable disease. We switched to CT scans because we see no longer I don't know, something to see more in the PET CT. So we had a MDT meeting. He was not a candidate for liver-directed therapy or PRRT at that point. And also a PRRT is actually very difficult to get here in our city. We only have one center and it's not always readily available. So the patient continued with lanreotide with stable disease as of January of this year. And in the last MDT meeting, the patient was considered to be a candidate possibly for a liver transplant. So he's currently being evaluated by the liver transplant team. And it's an option that we did not want to close the door to it. So as I said, this presents as a very difficult case for us because one of the first things that we see in the current guidelines, and we now think that we have guidelines for neuroendocrine tumors because a few years ago we did not have this. So one of the first things you see is that pathology review and the assessment of some markers, histology markers, are going to be able to our pathologists to distinguish between grade 3 neuroendocrine tumors and neuroendocrine carcinomas, because we know that these patients may have a favorable biology or unfavorable, but what we know is that these patients have a very different characteristics and behavior. So we're gonna go back this slide just to remind yourselves that this NET grade 3 is a very recent addition to the classification of neuroendocrine tumors, and one of the main things that we have to do is to ascertain that our pathologists are up to date with these classifications. When we see patients from clinics all over the country, we see a lot of heterogeneity of reports in neuroendocrine tumors. So one of the biggest efforts I think we have to do here is to try to establish like a central review of pathology if possible. And as I said, we can help ourselves with some markers as P53, RB, or P16, which are commonly more expressed in the neuroendocrine tumors rather than carcinomas rather than neuroendocrine tumors. And as I said, this is a very interesting and recent review of grade 3 neuroendocrine tumors, which I encouraged you to look for, and they present the characteristics of these patients. And as we can see, we see now these grade 3 tumors, the main locations obviously is in the pancreas, but we see that the average of, for example, Ki-67 above or equal to 55, most of the patients with do not have this Ki-67 over 55, and in some patients, the majority of them are positive to SRI. So and also positive for PET CT. So as these patients. He had positivity on both studies, so we cannot remain only on imaging to distinguish these two entities. And as I was saying, we have to distinguish these two entities because they have clinical behaviors, completely different clinical behaviors, and also a different survival behavior. So, and the other thing is that this have different responses to chemotherapies. As we can see in the graph on the right, the overall response rate and the efficacy of platinum etoposide first-line chemotherapy is lower for grade 3 NETs in contrast to neuroendocrine carcinomas. So what we can expect with first-line chemotherapy, as we see, as we have seen in this patient, is really a smaller response with stable disease in the majority, and the majority of them progressive disease. So this patient will be progressing on first-line chemotherapy in some cases. So as I was stating, this patient had a favorable biology because he had a low K67 and a slow-growing and positive SSTR PET. So what we opt for this patient, as guidelines mandate, is to start with lanreotide in this case. This patient, I have to remind you that he was asymptomatic and he was a really fit patient and very active. So we wanted to not to put a burden in his quality of life with therapy. So so what is the role of somatostatin analogs for advanced PNETs? We know 2 studies. So the best evidence for pancreatic NETs is with lanreotide. I think we have stronger evidence for the use of lanreotide, and it's our choice of treatment in most cases. But we have to remind ourselves that all the clinical trials that I'm about to present, somehow the population for a grade 3 neuroendocrine tumors is underrepresented. So when we have these cases, we have to actually consider a lot of things to treat our patients, because there is up until now no specific randomized control trial for these patients in particular. So lanreotide for these patients, obviously we choose this treatment for patients with a slow growing biology, non-progressive tumors. Okay, so we have to mention obviously the excellent trial led and presented beautifully by Dr. Pamela Kunz in the last ASCO meeting, which is one of the few randomized trials we have on phase 3 randomized trials of chemotherapy. And to explore the role of chemotherapy, we know that streptozotocin was a historical standard of care for some of these patients, and then temozolomide, and now we have combination chemotherapy for this patient. So the primary endpoint for this study was progression-free survival, so which was met for this, and with a clear trend, although non-significant, non-statistically significant for overall survival. But this trial was very interesting to see in terms of a response rate. We have a 40% response rate for these patients, and one of the most interesting things of this study is the addition of the MGMT deficiency as probably a marker for treatment response, and some of the very few markers that we have, or predictive biomarkers we have on NETs to predict response to therapy. Although this was investigational, is obviously we see that patients with a MGMT low have a better response to temozolomide. So this might be in the future further explored, and it may possibly be a new biomarker of response. And we have another option, as the guidelines stated, with FOLFOX. It's an active regimen for grade 3 pancreatic neuroendocrine tumors. As we see in this review, we can achieve some stable disease, especially in patients which had a response to platinum first-line chemotherapy. So FOLFOX is an active regimen, and we can consider it as this patient was actually not progressing to platinum therapy, but he had stable disease as his best response. So this could be an option. Obviously, we have targeted therapies for advanced PNETs, and we have to remind ourselves that sunitinib and everolimus are the range of response rates very, very modest, with a 5 to 9% of response rates. We have an advantage of progression-free survival, which is going to be like the main advantage of this therapies, and it all comes to the toxicity profile that we are able to accept for our patients, and our patients are able to tolerate. As I was saying, the principal symptoms of everolimus is stomatitis, rash, diarrhea, and diarrhea, nausea, and asthenia for sunitinib. So it all comes, as I said, with the toxicity. So what about PRRT for grade 3 PNETs? Actually, well, we have this very interesting study published in 2019, and we see that there is a role of grade 3 NETs in terms of we do not see many complete responses, but we do see partial responses of 42% and stable disease in the majority, in the most half of the patients. So with a PFS of 19 and an interesting overall survival of 44 months. So, and this has to do also with the expression of Ki-67. So there's a role of PRRT, especially in patients progressing. But the downside of this is that obviously it is very difficult to, at least in Mexico, we only have like 2 centers that offer, and the whole country PRRT is difficult to get. So, and also expensive and not reimbursed by the majority of the public health system. So, which is a grain down. So, what about immunotherapy? We have some studies, not specifically, as I said, in grade 3 neuroendocrine tumors, but we do have some trials in PNETs. So we achieve partial responses in about 1/4 of patients with a 6-month progression-free survival of 35%. In my opinion, the study that shows the most benefit for neuroendocrine tumors is the combination for nivolumab and ipilimumab. So it is an option. Specifically in which patients we would obviously try immunotherapy in those rare patients that have a high tumor mutational burden or MSI, sorry. Patients with microsatellite instability would be the actual candidates for this treatment with immunotherapy. And this was a study showed recently at ESMO Congress last 2 years that showed the combination of nivo and ipilimumab, especially in patients with neuroendocrine carcinomas, which will be addressed by Dr. O'Connor later in the talk. So sorry, this is not advancing. Okay, as we were saying, this was the PRRT, and so we can summarize in this slide the efficacy endpoints in NET3, grade 3 NETs. So we have, as I said, capecitabine and temozolomide, with chemotherapy being strong options for this patient, with a stable disease with partial response in 35% of patients. So if we want to have the response in these patients, capecitabine and temozolomide is a great option, with a PFS of 9.4 months and overall survival of 40 months for these patients. PRRT is an option, as I said, in second line where available. Etoposide and platinum is an option when we can expect lower response rates for these patients, as we saw in the first slides. As I said, FOLFOX is also an option, and targeted therapy with everolimus or sunitinib is also an option, although with very, very modest response rates and I would say a higher toxicity profile for our patients. So again, thank you very much for the invitation, and I'm eager to hear your questions, and Dr. O'Connor's will be following. Thank you.
Thank you so much, Dr. Bergette. That was such a interesting discussion, and to understand how, like, you know, this question, this conundrum comes up every time in practice of well-diff versus poorly differentiated cases. But we're going to save the questions to the end. Please, everyone, make sure you ask questions. Now we're going to move on to the next talk, which is Dr. O'Connor, and he's going to talk about poorly differentiated cancers. Thank you.
Hi, Ina. Thank you very much for the invitation. Let me just 1 minute to share my presentation. So I think that it's great. Okay, again, thank you very much for this invitation. I think that it's very interesting to sharing the experience with the expert from LATAM and also with the most experienced doctors in United States. Thanks all staff, NANETS staff, and also Camilo for great and big effort to make that happen. This interesting webinar. So. Let me start with the session of my clinical case. In this session of the based on the controversies in medical therapy, maybe I start with another. I would say another story between the clinical spectrum of the neuroendocrine tumor. This is our clinical case. It's a real case. 49-year-old man. He presented weight loss in the last 6 months of. Based on reference of our patient, not remarkable family history for our patient. So at the very beginning, in February 2018, he complained of abdominal pain, no other important symptoms to refer. And the first CT scan shows a suspicious lesion located in the second portion of the duodenum. And also, part of the first presentation was the obstructive jaundice, and RCP was performed, and endoscopic ultrasound revealed enlarging papilla at the initial staging. So the surgical team decided to offer the upfront surgery for our patient, and duodenopancreatectomy was performed in March 2019. So this is the first report of the pathology. As you can see here, duodenal surgical resection, the tissue sample cephalic duodenopancreatectomy, and exophytic lesion 1.5 centimeter located in the duodenum, with the dissection of the peripancreatic lymph node in the tissue sample. What about the final report of our clinical case was mixed tumor, neuroendocrine, and also non-neuroendocrine intraampullary tumor with the undifferentiated to large cells plus adenocarcinoma in situ in the ampulla location. This was based on the last classification of WHO 2019. This is a NEC G3 with Ki67 90%. And undifferentiated large cell carcinoma was reported, 0 out of 12 lymph nodes in the final report of the pathology, and also the PT1, PN0, and stage 1 for the NEC component. Let me point it out that the NEC-G3, in our case, the NEC-G3 was a lesion that 4 millimeter, less than 1 centimeter, with this very aggressive histology. Final report, as I mentioned before, the neuroendocrine carcinoma large cell of the ampulla of Vater, G3 4 millimeters, and also more than 20 mitosis per 10 HPF. And you can see here the immunohistochemistry for our patient, and also the adenocarcinoma in situ was the non-neuroendocrine part of the tumor. In terms of the some tumor marker in our case, the chromogranin A was normal, and the CEA and also CA19-9 was also normal. We decided to perform first 18 FDG PET-CT as an initial staging for our patient because the very aggressive histology, and you see here some diffuse increase in radio tracer uptake in relation to residual in the surgical bed, and also some laminar collections in gastrohepatic omentum. Our interpretation was only sequela after a surgical approach, non-active disease at that point. So I think that's the first question, dilemma. in terms of the adjuvant treatment, because we have the discussion in the MDT about how is the benefit, pros and cons of the treat our patient with some adjuvant treatment in a lesion less than 1 centimeter, stage 1, but just to remind you the neuroendocrine carcinoma component. This was the resection R0, and also the PET FDG showed no active disease at that point. So if the question is, where is our patient in this spectrum of the biology behavior of the neuroendocrine, probably is the worst prognostic factor, the Ki67, and also the neuroendocrine carcinoma. So it's different to the NET-GC, just to remark this in terms of the comparison with the other case with the NET-G3. But in terms of the this discussion, it is important to know how about the duodenal neuroendocrine tumors. 1 to 3% of all duodenal neoplasms that define at least 5 subtypes, non-functional, for the most frequent, most common in the duodena, more than 80% in the recent series published. And also duodenal gastrinoma is less than 10% in the same series. Somatostatinoma, very rare. Duodenal gangliocytic paraganglioma, rare. And also the high-grade, poorly differentiated neck and aggressive histology that was our case for discussion. 90% of the duodenal neuroendocrine tumor are proximal, in general less than 2 centimeters, and also 20% of the cases are located in the periampullary region. If we are looking for some answer in the different international guidelines, you can see here some recommendations by the NANETS, the European Society. I have the privilege to taking part of the first guidelines in high-grade gastroenteropancreatic neuroendocrine tumor. As you can see here in the neck and then also G3 neck, after resectable disease, there are some recommendations in terms of the option of treat our patient with the chemotherapy. But it is important to know there is a very limited data and probably low level of evidence for that. There are also some regional and regional guidelines that provide some answers in the same line in order to give some chemotherapy in a case of a patient with the neuroendocrine carcinoma, as you can see here from the GTG in Brazil, and also some local guidelines developed in our country and just published in the Spanish version in 2020. So after discussion and considering the age of the patient and the very good clinical condition and also the aggressive histology, we decide to treat our patient and offer an adjuvant chemotherapy based on the probably standard scheme, platinum-based for 4 cycles. And also he developed some toxicity with this skin, anemia grade 2, and also neutropenia that require GCSF as a support, and finish the treatment after these 4 cycles. In terms of some data based on the epidemiological differences between lung neck and extrapulmonary neck, I think that this is a very interesting paper from the United States and also from the study et al. That they show in most of the cases, more than 90% of the cases, the most frequent is located in the lung of the neuroendocrine carcinoma. Less than 10% of the cases are in extrapulmonary tissue, and 1/3 of these are located in the gastrointestinal system. You can see here the differences between the in different organs, and the most frequent in terms of the in gastrointestinal system are the colorectal location, and also some upper GI is less frequent, but also is part of the some location for the neuroendocrine carcinoma. And also interesting to remark is the proportion of the small cell and large cell. You can see here, for example, in small intestine and also in colon, probably more higher proportion of large cell comparing with the small cell. I'm not sure if there's some a big difference in terms of the prognostic and also treatment sequencing for this difference, but it is important to know some differences between the lung and also extrapulmonary next. The other part of the story is what about the differences between the neuroendocrine carcinoma of the ampulla versus or in comparison with the other neuroendocrine tumors from the same location. You can see here some differences in the very recently or interesting paper published by La Rosa. For example, 22% of the cases were neuroendocrine carcinoma in this series, and also some difference probably as expected in terms of the tumor size for the primary tumor, and also mitotic rate and Ki67 that was much higher in the patient with the neuroendocrine carcinoma, because it's a different story if we compare with the well-differentiated neuroendocrine tumor. So how is the evolution of our patient? This is just to remind the PET-CT that was performed in March 2019. And also take a look 6 months after the first PET-CT. You can see here there's some liver lesions and also some necrotic in the some lesions in the liver. And also this is another picture of the how is the clinical situation 6 months after the surgery of the primary tumor. And again, you can see here some new liver lesions and also necrotic and probably rapid progressive disease in the liver. So this is the description of the different lesions, bilobar lesions located in the liver. So the other question at that point is what is the best approach in terms of the second line for the patient with a neuroendocrine carcinoma, and I would say rapid progressive within the 6 months after surgical approach. So let me review some data from the literature and also interesting paper published by Dr. Lamarca and et al. About the second line treatment in patients with advanced extrapulmonary poorly differentiated neuroendocrine carcinoma. I think that it's a busy slide, but it is important just to remark the bad prognosis. If you see here the PFS and also the overall survival for all patients less than 6 months and less than 12 months in average for this this type of tumor. And also if you see here different scheme, because it's not there are no standard treatment for the second line treatment for neuroendocrine carcinoma. What about our experience? There are some characteristics of some patients included in a collaborative work with Dr. Paula Montenegro and Richard from Peru and Brazil. Take a look at the differences in terms of the first line, probably not as expected, some scheme platinum based, and also in second line, but very heterogeneous population in more than 100 patients included in this cohort, and also some other different chemotherapy scheme, not target therapy. And probably the most important thing, if you see the surgery approach in our experience, in our series, less than 10%, because the reason is that 90% of the cases are presented with the synchronous metastatic disease. So this is the probably the worst prognostic factors associated even with the this aggressive histological subtype. In terms of the probably it is important to know more about the molecular profile of this kind of tumor that are more interesting interest in the to know more about the molecular profiling. This is our I would say small experience in this field with some 17 patients treated in our working group. The 80% of the cases with the neuroendocrine carcinoma, In all cases with RB and P53 expression abnormal, probably less than 2% of the dMMR patients, just I mentioned before, probably is less than reported in the literature, and also some expression of PD-L1, but we don't know exactly what is the role of as a predictive factor for immunotherapy for PD-L1, at least in this field. KRAS mutation, 30% of the cases, in all cases in our study in neuroendocrine carcinoma, and also all patients with BRAF wild type. And also interesting to know, at least just as presented by the Brazilian group, differences and also multivariable analysis in terms of the prognostic factor, and they showed that the only factor related with the prognosis with the subtype, histological subtype, so NEC history versus NET history, in this interesting experience, more than 70 patients presented in it a couple of years ago. So after that, we decided to offer a second-line chemotherapy for our patient with this modified FOLFIRINOX, just in order to include the irinotecan and the good clinical condition. This is what the final decision for second line in the MVP of our patient. In terms of the target therapy, the question is if we how to move to the next generation, I would say, treatment for the NEC, and probably there is some new data coming from that was presented in ESMO this year, but probably not very promising in terms of the target therapy and also immunotherapy. This was the NICE NEC trial that was in a cohort, and after screening, induction phase, and also maintenance phase treatment with the combination of nivo and chemotherapy, platinum-based carbo and etoposide. That was 70% of the patients included in this series, and also 54% of them overall response rate. At least, let me say that probably there is some signal of activity of this kind of treatment for neuroendocrine carcinoma. And also interesting to that there was presented in ESMO last year in terms of the location of the primary tumor, probably more signal of activity in neck, but non-colorectal neck. So the location of the primary tumor and also the pattern of metastasis, probably it is some factor to take in account for the future. Unfortunately, data presented and also published recently in the BEVA-NEC trial that evaluate the result in terms of the chemo or chemo plus bevacizumab, just to in order to looking for the outcome with the anti-angiogenic adding to the chemotherapy, and was a negative trial, so no role now for any other target, unfortunately, in this setting. So what about the evolution of our patient? Just to remind, was in I think in April 2020, and there was an increase of the number of cases during the COVID-19. Just I mentioned this because you see here the new bilateral focal lung and parenchymal opacities with ground glass density that put on the table some differential diagnosis with the COVID-19. But unfortunately, there was in this regard, there was I saw some progressive disease, not only in the liver, and also, as you can see here, multiple osteolytic skeletal lesions, predominantly in the spine, and also a new and increase in size in the liver lesions, some more heterogeneous hepatomegaly after second-line treatment. To sum up our case, just to remind, in February 2019, very small lesion, less than 1 centimeter, but the neck component, the first PET-CT shows not active disease at that time. And after the adjuvant treatment, he had progressive disease less than or around 6 months after the surgical approach. After that, he received a second line. Unfortunately, no other signal of for some actionable mutations to treat at that point. And also after progressive disease, we decided to offer radiotherapy as a palliative care, and he passed away in June 2020. So in brief, there was the disease-free survival 7 months, the PFS 3 months, and all in all, the overall survival was 16 months. Again, just I pointed out in a patient with a localized disease, in addition less than 1 centimeter, but neck G3. So in conclusions, in terms of our clinical case, some take-home message, probably this is a very good data that was provided by the SEER population-based study in more than 160,000 patients with the neuroendocrine carcinoma. Just to remind you, most of them located in the lung. I think that it's a different story, probably different biology in the lung, and in contrary or in comparison with the extrapulmonary, and also in gastrointestinal tissue, less than 10% of the cases extrapulmonary location. 20% of the neuroendocrine neoplasms originating in the ampulla of Barton was described in the recent series, and it's a very aggressive disease also in this location as compared to ampullary NANETS. Just important to know some factors that were identified as prognostic, as the worst prognostic factors, in terms of the grade, obviously, patient age at diagnosis more than 60 years, and also some histological aggressive characteristics such as vessel invasion, pancreatic invasion, and also distant metastasis. In our experience, we have seen the aggressive nature of this type of tumor in a short survival for our patient. He received I think that's probably more standard treatment in terms of the chemotherapy. And I think that it's important understanding the biology and the molecular profile of this type of tumor is a clear pending issue in the search of some potential treatment target for this very bad prognosis disease. And also recent studies, as I mentioned before, have not been able to show the benefit or some favorable results in terms of the use of immunotherapy or other target therapy, at least for the recent data published. So this is my final slide. I would like to thank our group. This is the timeline for the Argentum group, and this is our working group created in 2005. And also there are people that they're working day to day with us in terms of the improve the taking care for the patient with neuroendocrine tumors in our country. Thank you very much.
Thank you so much, Dr. O'Connor. That was a very insightful talk and a very good description of a patient journey with a poorly differentiated carcinoma. So for everyone attending, please ask questions. Oh, I forgot to turn my video. Please ask questions. Please go ahead and type them into the Q&A session. If you have a question for a specific speaker, please go ahead and mention that too. So I'm going to go to the first set of questions, and this one is actually targeted to Dr. Bergette. About, we had, when we were talking about controversies, one of the interesting thing you mentioned was consideration of liver transplantation for this patient. And I was wondering, what is the practice in your area, and who is considered for liver transplantation, and how is that different in the US? And we have other panelists here on too who can talk about the same in Argentina or America as well.
Thank you. Well, this is a very increasing problem in our country. The access for specifically liver transplant is, as you can imagine, very limited, and so especially because Nowadays, we have a policy set up that all patients who are being considered for liver transplant are always are considered based on a list, but as in every other country. But the thing is that the organs stay within the same system. In the public system first, it goes first, and then if there are no matches, then they can go to patients in the private sector. So it's kind of difficult to manage this, and obviously patients with cancer specifically are very little considered for liver transplantation. But one of the things that is asked by most tumor transplantation committees is to have stable disease for at least 6 months before considering putting the patient into the waiting list. So this gives you a very short amount of time for the majority of diseases. With neuroendocrine tumors, we have a wider window of opportunity, but specifically for other cancers like colorectal cancer, for example, it's very difficult to achieve these and to have an organ ready for our patient in this time frame. But I have the fortune to work with the very prestige liver surgeons in my center, and so we have a wider program, a transplant program. We have great surgeons, and so they are very, I would say, open-minded to include patients with cancer. I can say that in other centers it's not the same priority for the surgeons. So that would be the case for Mexico specifically.
Thank you. Dr. O'Connor, transplant for G3 NET in Argentina? Yay, nay?
Yeah.
What is the thing?
I know. I think that it's a difficult topic and very controversial in terms of the who is the best candidate for transplant in neuroendocrine tumor. I fully agree with Alan in terms of the open-minded when we have to discuss this option for patients. Probably, I think the main discussions, at least in our country, is in the center that who have some doctors or transplant surgeons. That is the big difference, because it's not easy for all patients or in all, I would say, working teams to discuss this option, because it's not real for many patients. So I think that it's important. In our experience, we have some patients with the transplant, very selected patient. In general, we follow some, I would say, Mazzaferro criteria based on this important study published in the patient with the, I think that it's better for the gastrointestinal and also in small intestine, for example, after resection of the primary tumor, 6 months with a stable disease, and probably young patient. I'm not sure about the exactly cutoff of the Ki-67, probably less than 5%, but maybe less than 10%, and with high uptake of or high expression of the somatostatin receptor, probably it's a good candidate. And also in a patient with refractory disease, in some patient with the carcinoid syndrome, for example, I think that it's probably a good option. In our experience, I would say that in most of the cases that when we discuss this option, one of the main reasons that for non-transplant is the extrahepatic disease. That is the main problem, and I think that we have to select better our patient based on the PET gallium 68 DOTA-TATE, for example, but I think that it's for discussion in very selected patients.
Thank you. I know we have a few more panelists who have joined who didn't speak right now, but they're from US, Dr. Hapton-Orson, and I also see Dr. Suarez here and Dr. Hallett here. Any of you want to comment on the role of transplant for G3 population and what you think?
I can make a quick comment. My
Sure.
apologies, I'm not on camera right now because my talk is a little bit later.
Yes.
so not quite camera ready, but I will be actually speaking about neuroendocrine tumor liver transplant. Like G3s are typically outside of Milan criteria, and we know that transplanting outside of Milan criteria for neuroendocrine liver mets portends worse prognosis, and a prognosis that's actually worse than that of other known therapies, and that's for G1 and G2s. So I would say that for G3s, it's probably very, very off the beaten path, and I would try other therapies prior to considering transplant. I think it has to be better established for G1 and G2s before we can start venturing into higher grade lesions, but that's just a personal opinion. And stay tuned for my talk if you want to hear more.
Awesome. That's a perfect prelude to your talk. Thank you, Dr. Howlett. Right, let's move on to the next question. So Dr. Bolzico is asking that there's a problem accessing Cape-Tem, like so temozolomide in Brazil. And so what is the experience of the speakers in terms of, what can they use? Is dacarbazine or DTIC used by anybody? We'll just, what do you think, Dr. Borghetti?
It's no surprise that now in Mexico, I would say in the past 5 years, we have had a big issue with in terms of medication and access to drugs all over the country. But fortunately, capecitabine and temozolomide are accessible. I would say there are many brands that are in our country, so it's an option. It's not a very expensive option, I would say, for patients. So at least in the 5 past years, we have not had any problem with access to Cape-Tem.
And do you ever use, or has anybody used streptozocin? So I remember we used to use 5-FU and streptozocin, which is used in Europe too. But like that's an alternative. But I personally have not used dacarbazine, but I don't know what others. Dr. O'Connor, have you considered that?
Yeah, fortunately, in our country, we have to access to the Cape-Tem as a chemotherapy option. I have some experience with the dacarbazine some years ago, but now it's the access. Fortunately, we have the possibility to treat our patient with this scheme. Unfortunately, we don't have, for example, streptozotocin. We don't have any experience, or very limited some years ago, but not access to the streptozotocin in our country. I think that is the same situation in Latin America. Please, Alan, correct me. It's the same, or it's available in Mexico?
I'm sorry, didn't hear the which streptozocin. Yeah, it is available. It's difficult to get, but it is available. Yeah.
Okay. So yes, we have some experience with dacarbazine. Maybe we have used, like I have used streptozocin when I was training up until 3 or 4 years ago, but now essentially everybody gets Cape-Tem, as you suggest.
Yeah, the dacarbazine is not available in Mexico, at least. Yeah.
Yes. Oh, apparently Dr. Bolzico is saying they also use streptozocin a lot person. So we have one other question from a speaker about a question about dual staging of FDG and gallium PETs. So who do you consider dual staging for?
Yeah, well,
Dr. Borghetti, yes.
Yeah, thanks. So I would say that specifically patients, there's not such thing as a cutoff for this decision, but I would consider if patients are grade 3 NETs, but with a higher Ka67, the odds of having a positive FDG is higher. So I would say that patients with a Ka67 above 50 or 55, as the NCCN guidelines state, would consider it for 18 FDG. For the other patients and the gallium, if you're considering giving your patient SSRIs, I would consider gallium 68 for staging only. Yeah, only that case. Yeah.
Yeah. So we also know typically gallium is used initially for us just because SSTR sensitivity helps us decide for the G3 NET. For poorly differentiated high-grade carcinomas, that's not something we typically do, and I guess that's what how you do. And Dr. O'Connor, anything you would like to add for the PD, like the poorly differentiated one, any cutoff when you consider a gallium PET4?
Yes, I think that's not a perfect cutoff of the Ki-67, but I agree that in general we fight with our nuclear medicine all the time because she said, okay, it's more than 10%. It is better to perform the dual PET staging. I'm not fully agree, but I think that in a patient with the Ki-67 with some discordance in terms of the uptake of the 18 FDG, for example, between 20 and 55, probably in some cases, just in order to define the net G3 or a NEC, for example, and looking for if the uptake is homogeneous or heterogeneous, for example, because this is a big question for the when we saw the staging metabolic study, because not in all cases is very homogeneous, the uptake. So it's tricky, but I think that between 20 and 55%, I would say that in our experience, we're trying to perform the dual PET-CT.
Awesome. Thank you so much. We are at time now. So thank you, everyone. We didn't get through all the questions. Some important questions are still pending, but I guess that's all we have time for right now. We'll try to get them later in the day, but thank you everybody for joining. Thank you, Dr. Borghetti. Thank you, Dr. O'Connor. And for everyone, we'll be back at 1:50 with very exciting sessions, which you did get a small prelude to. So thank you, everyone. Have a good day.
Thank you. Bye-bye.
Okay. Hello, everyone. Welcome back. We are ready to kick off the second half of our program. Our next session is Controversies in NET Surgery. My name is Haidira de Rivero. I am an associated research physician in the developmental therapeutic branch at the National Cancer Institute at the National Institute of Health. It is my pleasure to introduce the speakers for this session, as well as an honor to be with you all today as a moderator. First, we will hear from Dr. Alexandra Ganji. She's an assistant professor and director of the gastrointestinal tumor program at Cedars-Sinai Medical Center, and she will be presenting on resection of the primary tumor in stage 4 disease for small bowel, as well for pancreas neuroendocrine tumors. Next, we have Dr. Calicia Clark. She's an associate professor at the Medical College of Wisconsin, presenting on surgery for pancreas neuroendocrine tumors when surgery is indicated in less than 2 centimeters, yes or not. We also wanted to say that congratulations, Dr. Calicia Clark, for being the president of the Surgical Academy Association. Following these 2 talks, we will hear from Dr. Daniel Anaya Sáenz. He is the chief of GI surgery and head of a hepatobiliary section in the Department of Gastrointestinal Oncology at Moffitt Cancer Center. And he will be presenting on hepatic cytoreductive surgery. Is there a limit? Next, we have Dr. Julie Hallett, and she's an associate scientist at Sunnybrook Health Science Center in Toronto, Canada. And she will be presenting on indications of liver transplant, the pros and the cons. And last, but certainly not least, Dr. Heloisa Suarez. She's an associate professor at Huntsman Cancer Center at University of Utah, addressing the question, is there a role for neoadjuvant and adjuvant therapy in neuroendocrine tumors? Following these presentations, we will take questions from the Q&A session, so please place your questions there. And let's get started now with the presentation from Dr. Ganji on resection of primary tumor in stage 4 disease for small bowel and pancreas neuroendocrine tumors. The floor is yours, Dr. Ganji.
I think I was muted. It's a better presentation if I'm muted. Okay, well, thank you very much for the organizers for allowing me to be here today. It's an honor to be here. I'm excited about this collaboration, and I've been tasked to speak to you today about primary tumor resection for stage 4 small bowel and pancreatic neuroendocrine tumors. I have no financial disclosures. The only important disclosure is that you have a surgeon talking to you about the role of primary tumor resection, so some opinions may be biased, and you can keep that in mind as we move forward. As you've already heard today, and most of you know, neuroendocrine tumors can arise in multiple different areas, and we'll be focusing on small intestine and pancreas primaries for this particular talk. And for patients with small bowel and pancreatic primaries, metastatic disease, actually patients present commonly with metastatic disease, with up to 42% of patients with pancreatic neuroendocrine tumors presenting with metastatic disease and 45% of patients presenting with metastatic disease when diagnosed with small bowel tumors. In determining next steps, typically when I see these patients in my clinic, the important question to first ask is if the disease is localized. I know that this is a busy slide, but the way to think of it is if the disease is localized in the metastatic setting, how bad is the tumor burden? So if a patient has a primary tumor in place and resectable or limited liver disease, for example, these are patients in whom you may discuss surgery as a first option, both for small bowel and pancreatic neuroendocrine tumors. A few additional nuances in the setting of pancreatic neuroendocrine tumors that can be discussed further later in this talk with respect to systemic therapies and roles of liver-directed therapies. But low tumor burden, metastatic disease, typically surgery does play a role. If there's a heavy tumor burden, this is a little bit more difficult. You could see this patient has bilobar metastases in the liver. This is not something that we can resect to negative or completely debulk to even potentially 90%. And so there's other options here that should be considered. And then if the patient has significant extra abdominal tumor burden, then the question is there a role for surgery at all? And if so, what is that specific role? So I think for purposes of this talk, we're going to focus more on that last cohort of patients. We can assume that if patients have metastatic disease that is resectable in conjunction with primary tumor that is resectable, that surgery should be acceptable and should be discussed in a multidisciplinary setting in terms of determining the optimal timing for moving forward with that. And while in these patients, a debulking of 100% is ideal, debulking to 70, 90%, at least with respect to their metastatic disease, is acceptable. We're going to focus on the unresectable metastatic disease patients. So small bowel neuroendocrine tumors, a lot of patients will present with small bowel neuroendocrine tumors, and rates of diagnosis have increased pretty significantly since the 1970s. As we talked about 50% of these patients will present with METSA diagnoses, a majority of them with liver metastases, and about 30% of them having peritoneal carcinomatosis that may or may not be visualized with preoperative imaging. Surgery for the primary tumor involves resection of the involved bowel and the associated lymph nodes, sometimes which presents as a fairly large mesenteric mass or masses. The guidelines for the resection of small bowel neuroendocrine tumors for the primary tumor in the setting of metastatic disease is in symptomatic patients. We agree that primary tumor resections should certainly be considered, but it's really in asymptomatic patients where this remains controversial. And both NANETS and NANETS guidelines acknowledge that there's a lack of prospective evidence that does not allow us to make definite conclusions about any potential survival benefit for these patients, and recommend that the risk and benefits of surgical intervention be considered when discussing primary tumor resection in stage 4 patients. Because truly, if the patient is asymptomatic, what are we improving with surgery? Well, this was a study from 1996 that looked at patients with or without carcinoid syndrome who had some kind of symptoms. There was a total of 121 patients who underwent primary tumor resection. Almost all of them had metastatic disease, primarily nodal metastatic disease, which is locoregional, and then 62% had liver disease. And if you look at the table on the right, you can see that patients with carcinoid syndrome primarily had diarrhea and flushing, not surprising, but those patients without the syndrome, a lot of them had abdominal pain, nausea, abdominal distension. Both cohorts had some weight loss. And in all of these patients who underwent primary tumor resection, 82% had partial or complete alleviation of all symptoms. You can see that here for all operations. And the time of symptom relief was about 5.3 years. So most patients really have symptoms and benefit from early aggressive intervention. These are representative pictures of my asymptomatic patients, okay? So if you look at these patients, they presented asymptomatic from their bowel primaries, but if you look to the left, you can see that there's some discoloration in the bowel. For those of us who look at intestines, we know that this is concerning. For those who don't, basically everything should look essentially the same color and nice and pink. So here, probably from the mesenteric mass, nothing has been resected at this point. From the mesenteric mass, there's some compromise to the vascular inflow. This is what we talk about when we talk about mesenteric ischemia. And when I look at this and the patient says, well, when would something bad have happened? I have no way of knowing. I don't know if it's going to happen in a month, in a year, in 3 years, tomorrow. It's impossible, but this certainly looks concerning, and you can see that there's vascular compromise. Similarly, in these two patients who seem to have a very similar tumor, these are, again, two patients who are asymptomatic, but you can argue that there's an impending obstruction. You can clearly see that there's mass puckering, and that's certainly concerning. And sometimes we just have pin-sized holes that we're able to see on the final specimens. So the reality is asymptomatic patients are not always asymptomatic. A careful history and physical will reveal symptoms from a small bowel primary tumor in over 50% of patients if you ask appropriately, if you ask the appropriate questions. The most common symptoms are abdominal pain, nausea, vomiting, and weight loss. These patients will benefit from resection of their primary tumor, if not from a survival perspective, definitely from a quality of life and potential downstream complications perspective. Truthfully, also, some patients will only retrospectively appreciate that they had symptoms from their primary tumor, right? A lot of patients, we've talked about rates of misdiagnoses for NETs. They've been living with vague discomfort, food fear, various different things for years and years and years. And they come to you, you discuss surgery, you take it out. And it's not until they see you 3-6 months later where they say, this is completely different than I felt for the last 5, 6, 7 years. So you may not always ascertain that patients have symptoms, but it is an important thing to keep in mind. How can, hypothetically, the resection of a primary tumor improve outcomes? Well, we talked about the prevention of obstruction, bleeding, bowel ischemia, and disease progression. For patients who ultimately will develop those things, they will less frequently require emergency surgery for the above. We know that emergency surgery has some optimal outcomes. These patients will frequently present with any of the above scenarios. Residual disease is frequently left behind. There may be inadequate lymph node resection. And so generally operating on these patients on an elective basis is preferred. What are the potential negative outcomes of the primary tumor remaining in place? Well, we can assume that it's likely going to continue growing. And with the exception of what we mentioned above, this could obviously lead to the tumor ultimately perforating the serosal layer and leading to peritoneal spread. Primary tumor and nodal metastases left in place may have the ability to shed tumor cells, so you may get continued new metastatic disease. It's unclear whether metastases shed additional metastases or it's the primary tumor that continues to shed new cells for new metastases to develop. And then now with the onset of additional therapies like PRT for these small bowel patients, not infrequently, if they have significant disease or a significant mesenteric burden, we do see some post-PRT fibrosis. Patients have peritoneal carcinomatosis. They may develop additional fibrosis and ultimately obstructive symptoms. And so in some scenarios, there's even concern for symptoms worsening, even if they're eligible for other therapies. So could primary tumor resection and debulking make them eligible for things like PRT and improve their outcomes that way? This is a fairly busy table, but it looks at a number of retrospective studies that have evaluated the role of primary tumor resection, primarily in patients with primary small bowel neuroendocrine tumors with concomitant liver metastases. And a majority of the time, the primary outcome was overall survival. In this study by Bennett et al., where Dr. Halle, who's on the panel, was a senior author, they looked at different outcomes, looking at acute care admissions and small bowel related surgery, because we know that these patients from a survival perspective do fairly well. So it's difficult to follow them, right, for a long period of time. But you can see that a majority of the time, the patients who received primary tumor resection had improved overall survival when compared to those patients who did not. The one exception was a study by Daskalakis, published in 2017, and essentially what they did was they propensity score matched patients who had primary tumor resection versus no surgery or delayed surgery. And in the non-propensity score matched group, you can see that, again, there was a survival benefit, but when they were matched, there was no significant difference. Now, what's interesting to note about this particular study is that in the delayed or no surgery group, out of the 91 patients in that cohort, 53 of them ultimately underwent small bowel resection, and 23 of them did so for actual symptoms. So the argument there can be made that you don't necessarily need to resect within 6 months of diagnosis, but continued close follow-up is certainly important in these patients if you're not doing a primary tumor resection, because a lot of them may ultimately develop some symptomatology. This is another study, meta-analysis that looked at a number of studies, again, with 1,200 patients with primary tumor resection compared to about 600 without surgery. And again, primary tumor resection seemed to be favorable. And they looked at patients who did not have liver debulking surgery, and primary tumor resection alone had decreased risk of death, again, suggesting a potential overall survival benefit. The important question, though, for small bowel neuroendocrine tumors is, what is the risk reduction for obstruction, bleeding, and mesenteric fibrosis? What is the optimal timing in these patients to move forward with primary tumor resection, and where should it fit in the armamentarium of the additional therapies that we have available? Secondly, is survival dictated by primary or distant disease? Well, we know that patients who have liver metastases, typically their survival is dictated by progression of that. But what is the role of primary tumor resection there? And then lastly, a majority of the data that I just presented is secondary to retrospective studies, where perhaps the overall survival benefit we're seeing is because we have selected patients who would have done better anyways, and that's why they were selected for an operation. So as devil's advocate, you certainly have to think, what are we trying to achieve? But I do think that for primary tumor resection for small bowel tumors can be curative in early stage patients. It may prevent future metastases. We do believe that it can prevent or alleviate bleeding and obstruction and ultimately emergent operations, and it may reduce circulating hormone levels. What about PNETs? Well, we know a majority of these patients will also present with metastatic disease. And we think certainly for functional tumors, resecting the primary may afford some degree of cytoreduction and symptom control. And even for asymptomatic patients, NANETS guidelines suggest that resection can be performed to prevent life-threatening and obstructive complications. Now, what's important when considering pancreatic neuroendocrine tumors is what exactly are you resecting and what additional therapies is the patient able to get, right? So if there's a tumor in the distal aspect of the pancreas, you're typically performing a distal pancreatectomy. If there's something in the head of the pancreas, you're typically performing a Whipple procedure, which creates a new bilioenteric anastomosis, which, if you're getting subsequent liver-directed therapy, may significantly increase your risk of infection when you're trying to treat the liver metastases. So this is of critical importance, right? Anatomy makes a difference. If you're considering an enucleation in these patients in a non-functional patient, one could argue that likely there's potentially going to be a limited benefit from resecting a primary tumor with an enucleation only because it's probably not doing very much. So location matters when we're talking about these patients. But if we want to look at it more globally, this was again a propensity score matched cohort study looking at patients from 3 tertiary referral centers that included a total of 733 patients with stage 4 pancreatic neuroendocrine tumors, all grade 1 or 2, and both functional and non-functional tumors were included. And here, if you look at the patient baseline characteristics, we're going to focus more on the after propensity score matching. Again, you can see there are equal numbers of patients with functional and non-functional tumors, a majority of patients having non-functional tumors. The majority of patients had tumors measuring between 2 and 5 centimeters in size. Patients did frequently have liver metastases, typically ranging from 4 to over 10 liver metastases in both groups. And then a majority of patients had extra abdominal metastatic disease. So in these patients, they were broken up to the primary tumor resection group versus the no surgery group. And you can see both in the unmatched and propensity score matched groups, there seemed to be an overall survival benefit with resection of the primary tumor. And this was yet another systematic review that included 7 studies, all of which, all but one, that showed a benefit 5-year and median survival improvement with surgery as compared to no improvement. So the pooled hazard ratio was 0.43 for primary tumor resection, and the increase in median survival for all these patients was about 14 to 46 months. The reality is we need trials to actually answer this question, but when you try to find a trial, basically it doesn't exist with the exception of one. And this is one that is currently ongoing, looking at primary tumor resection for asymptomatic patients with unresectable synchronous liver metastases taking place in France. It's an observational study. They're trying to enroll 50 patients, and the outcome measure is essentially survival, death due to small intestine neuroendocrine tumor. Why are trials for primary tumor resection so difficult? It's a rare cancer. We need multi-institutional and international collaboration. How do we define eligibility for these patients? Should we include patients with liver-only metastases versus extrahepatic metastases? And what would be the extent of resection? Would it be the primary tumor alone, the primary tumor with locoregional lymph nodes? What about equipoise? How do you enroll patients? Is this a double-arm study? Is it a single-arm study? And what is the appropriate outcome measure? As Dr. Halle looked at a previous study that was retrospective in nature, they did not evaluate OS and DFS. Well, they did evaluate it, but not as their primary outcome, but looked specifically at admission-free survival and bowel-related surgery. Maybe those are the appropriate measures, or obstruction-free survival. Maybe it's a quality of life outcome. But all of these are potential challenges in determining how to ultimately answer this question. So in conclusion, based on what we know on retrospective data, primary tumor resection for both small bowel and pancreatic neuroendocrine tumors seems to be associated with improved overall survival. The potential for selection bias is high, and the optimal timing of surgery in these patients is undefined. We do believe that primary tumor resection may prevent downstream complications and need for emergency surgery or repeated hospital admissions. And in truth, until we're able to definitively answer the question, the decision to offer primary tumor resection should be considered and should be determined on a case-by-case basis in a multidisciplinary setting. Thank you.
Thank you so much, Dr. Ganji for an excellent presentation. Next, we're going to have Dr. Carlicia Clark, and she's going to present surgery for neuroendocrine tumors when it's less than 2 centimeters, whether we need to do it or not. Thank you, Dr. Clark.
So first of all, thank you so much for having me. It's always a privilege to talk about neuroendocrine tumors, and in particular, pancreatic neuroendocrine tumors. And I've learned in my short career that when Heidi asks you to do something, the answer is always yes. So I want to say thank you so much for the invitation. I'm going to talk a little bit about surgery for small pancreatic neuroendocrine tumors, whether it's indicated or not. And I don't have any financial disclosures, but the main disclosure that I have for this talk is that there's a paucity of prospective data to sort of guide these discussions. And so what we're going to talk about in terms of the limited data that we have available is predominantly retrospective cohort reviews, as well as multi-institutional retrospective cohort reviews as well. So, the challenge with pancreatic tumors, neuroendocrine tumors, as Dr. Ganji so eloquently talked about, is that they're still quite rare. About 2% of all pancreatic neoplasms, and the biology and how they respond to treatments is very different than pancreatic adenocarcinoma, and very significantly even within the heterogeneous group that are neuroendocrine tumors. Despite being rare in incidence, their prevalence is relatively high because these patients live for a really long time. And as long as we don't convey significant treatment-related toxicity or morbidity, for the most part, patients will live much longer than their pancreatic adenocarcinoma cohorts, for example. And these are quite diverse, and they're also then variable in terms of symptomatology. The functional tumors can they can either make or produce hormones that cause a clinical syndrome, probably the most common one being insulinomas. And these tumors can be very tiny, but the amount of hormone that they secrete can be quite significant even for low volume disease. Other rare functional tumors are listed here, but the vast majority of them are non-functional. About 80% of these tumors don't actually produce a hormone or peptide that's active. And so for that reason, they're often found incidentally in most sporadic cases. The behavior of these tumors, again, widely varies by a lot of I think factors, the main one being the tumor grade, with G1 tumors being quite indolent. Even with their metastatic potential, these patients tend to have a longer disease course. And it's unclear, especially in localized tumors that are quite small, what the natural history of those tumors would be if we didn't intervene surgically. On the other hand, grade 3 tumors or neuroendocrine carcinomas, even at very, very small sizes, can be very aggressive, with their morbidity and mortality from distant metastasis being quite high. These lesions are pretty unique on cross-sectional imaging, and that's how they're often diagnosed. On CT, they tend to be hypervascular, and the sensitivity of CT and MRI to detect these lesions is actually quite high and getting better over time, with the increasing sensitivity with increasing size. And then the advent and introduction of dotatate PET has really revolutionized not just the diagnosis of these lesions, but also evaluating the total burden of disease, and especially in terms of characterizing lesions that are indeterminate on routine CT scan or MRI. And so dotatate, just for I think some further elucidation, is a functional scan that enables us to take advantage of the fact that these neuroendocrine tumors express somatostatin receptors, and we can basically tag a molecule that has high affinity for these receptors that is able to augment the visualization of these lesions on CT scan. And I think in most centers, a dotatate avid lesion alone is usually adequate for diagnosis. And so we've particularly gone away from EUS biopsies to confirm diagnosis in all of these lesions, but I know that that's still up for debate, and we can talk about that a little bit later. The overall result of these increasing technologies and the increased sensitivities of these scans is that there's been a dramatic increase in the incidence and diagnosis of pancreatic neuroendocrine tumors, and especially in small neuroendocrine tumors that are actually asymptomatic and non-functional. We're scanning people more often, and because we can see these lesions now, we are actually diagnosing them more frequently. And so the question is, once we find these small incidental non-functional pancreatic neuroendocrine tumors, what do we do with them? And specifically, do all of these lesions warrant surgical resection? So I think there's certain things that go into the consideration of, asking this question and just generating a hypothesis. What we know from retrospective studies is that the vast majority of these small incidental PNETs are actually most likely to be low-grade gray 1 tumors that are going to be fairly indolent and are unlikely to cause significant morbidity or mortality over the lifetime of the patients. So this is a study that looks at 145 patients that had pathologically confirmed pancreatic neuroendocrine tumors, all less than 2 centimeters in size. In this study, 90% of them were G1 tumors, and only about 9% of them were either grade 2 or grade 3. There was a higher probability of having a grade 2 or grade 3 tumor if the PNET was actually greater than 1.5 centimeters. And in terms of poor outcomes, the things that were associated with either metastasis or development of nodal or distant metastasis were advanced age, tumor growth of the primary greater than 20% in size, or obviously if you had a higher grade lesion that was grade 2 or grade 3. So I think this really had a lot of us thinking, well, are we really operating on patients more than they need to? So if 90% of our patients could probably be safely watched or observed, why are we basically conveying additional morbidity? And so I would say approximately in the last decade or so, a lot of people have postulated that we are in fact overtreating some of these lesions. And it really started a conversation and quite a bit of dialogue about the management of these small, non-functioning, asymptomatic pancreatic neuroendocrine tumors. And as surgeons, I think it's really interesting that we were leading a lot of this work and a true, unbiased opinion about whether or not surgery was actually helping or potentially hurting our patients. And so there was an explosion of small cohort studies to try to investigate whether or not it was safe to observe these tumors. And many of them actually looked at their retrospective data and realized that most of these incidental tumors were actually quite benign and indolent, and that the majority of them did not metastasize or grow. And almost none of the patients died from their disease, even though the follow-up in all of these studies was quite limited. On the other hand, in the patients that underwent surgical resection, there were some significant adverse outcomes related to pancreatectomy in these patients. And so with small neuroendocrine non-functional tumors, the discussion is always about trying to weigh the risk of surgical morbidity and complications versus the real benefit oncologically of actually managing these patients surgically. Also from these studies, we found out that there was increased metastatic risk, but that increase seemed to exponentially increase after the tumors were greater than 2 centimeters in size. Obviously, if patients had positive lymph nodes on imaging, this was also a harbinger of bad disease and bad biology. And tumor grade 2 and grade 3 disease was actually much likely to be more associated with tumor progression and metastasis. So sort of based on, I think, large analysis of retrospective data, the major neuroendocrine tumor societies have created guidelines about the management of these, but there really is not good consensus between all of the societies. So both the NANETS and the Canadian Neuroendocrine Tumor Society usually recommend observation for lesions that are less than 2 centimeters in size. The North American Neuroendocrine Tumor Society recommends observation for lesions that are 1 centimeters in size or less. And then for the lesions that are between 1 and 2 centimeters, it's a bit of a gray zone, and they advocate for individualized approach to management of these tumors. Now, really the only prospective data that we have that is coming out of the ASPEN trial, and this was a recently published interim analysis of the ASPEN trial that basically is looked at patients that were diagnosed with small pancreatic neuroendocrine tumors that are non-functional, less than 2 centimeters. And the goal was actually to observe most of these patients unless they had high-risk lesions. High-risk lesions were based on imaging characteristics that included either evidence of positive lymph node metastasis at the time of diagnosis, abnormalities in the main pancreatic duct that were concerning for more aggressive tumor biology, any evidence of distant metastasis. And for all other patients, and also whether or not they were PET avid on FDG, which in general may be an indication for higher tumor grade. If patients had none of those lesions, they were observed. And so here we are, this is the cohort of essentially 500 people. And in that cohort, 406 patients underwent active surveillance with cross-sectional imaging at 6 months and then at 1 year, and then annually thereafter. And then 94 patients who underwent surgery for usually concerning features on their cross-sectional imaging. Now, it's important to note that the median follow-up for this study was only 25 months, so there's still more data that we need to get on these patients long-term. But in that, on this interim analysis of these 500 patients, only 3 patients died, and all of them died of other causes. There were no neuroendocrine-related deaths in this group. There was 1 patient that had disease recurrence. This was a patient that was in the surgical arm. He had neuroendocrine liver metastases at diagnosis. And so as we know, those patients are more likely to fail again distantly. So he developed additional liver metastasis. In the observation group of 406, only 9 patients converted to surgery. 4 of these patients converted to surgery because they had tumor growth greater than 5 millimeters in size over that 1-year period, or they had a greater than 20% increase in the size of their mass. 3 patients were converted to surgery because they developed main pancreatic duct abnormalities, primarily dilation. Again, that may be a harbinger for more aggressive disease. And then 2 patients preferred to undergo surgery because of, I think, the anxiety that was related to repeat scans and surveillance. But overall, this was a very successful observation arm, and the failure rate was quite low, which I think is very helpful. In our own MCW data, we're looking at what we've done here at our institution, and we basically made the switch to observation about 4 or 5 years ago. And so basically we wanted to look at patients that were referred to the surgical oncology group for small neuroendocrine tumors, and we wanted to find out what happened to those patients before and after the observation change. So we had 77 patients who met inclusion criteria. Mean age was 65 years, and our follow-up was 30 months. Our mean follow-up was 30 months. None of the patients died from neuroendocrine tumors. Again, 3 patients died from other causes, 1 from COVID pneumonia, 1 from prostate cancer, and another one from an unknown cause, but was quite elderly in age. Of course, most of these tumors were located in the pancreatic head, and the median size was 1.1 millimeters. So prior to or switch to observation, 31 of these patients underwent surgical resection. 6 of them were enucleated, 16 distal pancreatectomies, 6 Whipples, 2 central pancreatectomies, and 1 total pancreatectomy. And this was a patient that had multiple small pancreatic neuroendocrine tumors. Of that surgical cohort, about 13 patients developed some complication. Only about 6% of these complications, however, were grade 3. 3 of the patients had node positive disease after on their surgical resection, but in these patients, 2 of them were grade 2 and only 1 of them was a grade 1. And actually in all 3 patients, they had evidence of nodal disease at the time of diagnosis under cross-sectional imaging. In the observation arm, we had 46 patients, and none of these patients have developed distant or nodal metastasis on cross-sectional imaging. Only about 3 of these patients, or 7%, have had an increase in size greater than 20%. None of them have exceeded the 2 centimeter in size cutoff, and so we are continuing to observe these patients. And none of the patients have been converted to surgical resection at this time. So our algorithm here is that once a patient is diagnosed with a suspicious lesion on cross-sectional imaging, usually a hypervascular lesion on CT scan, we proceed with a dotatate PET. And if it's PET avid, we often do not undergo an EUS biopsy because, again, we know that the vast majority of these lesions are going to be grade 1. And even if they have a higher grade, there's usually evidence of either nodal metastasis or distant metastasis at the time of diagnosis in the majority of these cases. If they are symptomatic or functional, or if there's abnormalities in the main pancreatic duct, or evidence of nodal or distant metastases, those patients go to surgery. And we typically are recommending a standard resection with a regional lymphadenectomy, or if they undergo a parenchymal sparing resection or enucleation, we will typically also do a regional lymphadenectomy. For non-functional peanuts that are less than 2 centimeters, we assume that these are going to be grade 1 on dotatate PET. And in the absence of any worrisome features or any functional tumors, then these patients are observed. We do 1 cross-sectional imaging at 6 months, and then we do annual scans thereafter. And we will obviously intervene if these tumors change or develop any additional signs of bad behavior. So I want to say thank you for the opportunity to talk about this, and I hope this at least has generated some discussion amongst everybody attending here. I really don't think there's any right answer or wrong answer for this. I just had a patient who is 36 years old with a 1.5 centimeter tumor, and her anxiety level about these repeat scans is pretty high. And so for that patient, we're actually going to intervene surgically, but it's a very nuanced discussion. And I think as long as we give the patients the appropriate information, they can make the right decision that is the best one for them. All right, so thank you, and I welcome any questions.
Great. Thank you so much, Dr. Clark, for a fantastic presentation. We do have a couple of questions, but we're going to save those questions at the end. Now we have Dr. Daniel Anaya Science, and he's going to discuss about hepatic cytoreductive surgery and if there is a limit for that. Thank you, Dr. Anaya, the floor is yours.
Thank you so much, Heidi, and for inviting me and this great opportunity. It's really an honor to be able to be part of this first Latin American meeting on behalf of NANETS and the whole group, and to share the podium with all my esteemed colleagues. And so I will be talking about the surgical treatment of neuroendocrine liver metastasis. As many of the other topics that you have heard, there is limited prospective level 1 data. So we try to put here some of the data based on, or the judgment based on the data that is available and some of our clinical experience and some of our disclosures. And the goal is really to try to go over the imaging, the diagnostic, the indication for surgery, and recognize some considerations for surgery. So, it's important to talk about this because the vast majority of patients actually present with a liver and metastatic disease. If you look at this, an old paper that looked at the natural history of neuroendocrine tumors in the US from a cancer registry, and you can see that the incidence of metastatic disease ranges between 20 and 70%. And usually what we cite patients is that most of the patients present with about 50% presentation with metastatic disease, liver being the most common site of metastatic disease. And prognostically is very important because, like in other cancers, the survival is significantly impacted by the stage of diagnosis, distant metastasis being, of course, the most advanced stage. But despite that, when you look at neuroendocrine tumors, there is significant variation and significant heterogeneity in the patients. This is just an update kind of natural history study as well, more recent, in which you look at the actual survival based on the disease of presentation as well, the different stages. And you can see on the graph on the figure on the right side that even by the different stages, which are different colors, there's a lot of variation depending on the site of metastatic disease. And this is only one of the features that is very variable. I think you heard already Dr. Ganji talking about the difference in outcomes from small bowel to pancreatic, and there's, of course, many other sites. But beyond the site of primary disease, there's multiple other important features that one needs to consider when we're thinking about how to treat or manage one of these patients. It's really the essence of individualized and multidisciplinary care. These are all some of the things that we think about when we see a patient with these tumors. You know, is it asymptomatic? Where is the primary? Is it functional or not? Do they have prolonged disease that presents with carcinoid heart disease? What's the stage? What's the grade of the tumor? Is it resectable? Are we trying to do a complete resection, debulking, or is it unresectable? And what's our goal of therapy? And that's not even considering some of the age and comorbidities issues, as well as the alternative treatment options that have come up to surgery, including, systemic targeted therapies, radionuclide therapies, and transarterial therapies. But when you look at and because of all this heterogeneity, it's very difficult to really compare apples to apples when you're trying to determine what the best approach is. But when you look at the majority of the studies, those patients that can undergo surgery and do undergo surgery through following some strict criteria do present with higher survival outcomes. This is a recent meta-analysis in which they looked at surgical outcome of survival outcomes of surgery and other therapies. In the first graph on the left, you can see that surgery was better than any non-surgical options, and similarly surgical compared to chemotherapy or to embolization. It was associated with a better hazard ratio in regards to survival. But at the same time, the same study showed this graph on the right upper part of the slide, in which you can basically see that the risk of bias was significant. And it was significant for multiple different reasons. And although this is very important to understand, there's of course a huge selection bias of those patients that go to surgery. It's important to also know that when within some defined criteria, we do take these patients to surgery, there seems to be a historic survival benefit to historical controls. And some references that I want you to consider when you look at all the papers that have been published. In the past, the median survival of patients having surgery for liver resection for neuroendocrine metastasis was in the order of 50 months. And we are now seeing publications that extend to up to 150 months. The 5-year survival traditionally has been considered to be in the 30 to 40% range, like that first study that I showed you. But more recent studies or more high-level, institutional, high-volume studies have shown that this 5-year survival can be expanded to 60, 70, or up to 90%. With 10-year survival in the range of 50 to 86%. So we don't really see these survival outcomes in patients that go non-surgical therapy, although caveat the issue of the selection bias. And then when we want to determine the resectability and we want to kind of abide by those defined criteria, it's critical for neuroendocrine liver metastasis to really understand what the extent of disease is. So that's why I wanted to emphasize the imaging options. We have anatomic and functional image. This is a patient that had basically a small bowel neuroendocrine tumor with liver metastasis. You can see the basic anatomic images is an ultrasound on the left and a CT without contrast on the right. And you can see one lesion there, a kind of subcapsular lesion on the right lobe. And then when you look at the CT scan on the left, which is a venous phase, you can see that the lesion, you can see it a little bit better. When you see the arterial phase, you see that there is now 2 lesions, one that we had seen before and another one more posterior by segment 6 and 7. But I want to emphasize that for these patients, an MRI with a hepatobiliary phase, what we call here MRI with EOVs, is actually the gold standard when we want to really define the extent and the number of lesions. You can see that in this MRI EOVs, you can actually see the 2 lesions that we're seeing in the arterial phase and an additional 3rd lesion close to the hilum. That is not as clearly seen in the other 2 phases. So very critical to be able to understand the anatomic imaging, number one, to determine the number of lesions, the distribution of lesions, and the relation to intrahepatic critical structures. And then we go into functional images, which is basically primarily based on the PET dotatate scans. And you can see here that you can see the lesions, but you can also see the mesenteric mass towards the center of the abdomen. And the goal of this image is basically to determine if there is somatostatin receptor expression, which is associated with biology. It also will guide you for the choice of subsequent therapies like PRRT. It helps you determine better the number of lesions. However, you have to be aware of the false positives. like you saw there, you have to be able to window the images and understand that the lesion size in the PET DOTA tape is not correlated with the size of the actual lesion, but more with the functionality. But it's also very important for extrahepatic disease. So when we talk about surgery for these patients, I think we do, I group it in three different types of goals. One is to achieve symptom control, which includes for palliation. Number two, to target cancer control, and this is measured with survival benefits, either progression-free survival, overall survival, or some related survival benefit outcomes. And also to integrate with other therapies that may include, liver-directed therapies, systemic therapies. And you can measure these by either measuring survival benefits, but also maybe other outcomes that are important for the patient, like quality of life, like being off other systemic therapy for a longer period of time and so forth. So we'll talk about this. The issue of symptom control, which is not really a common indication that we do for liver resection, but the issue comes from this classic paper that was published by Dr. Sarmiento, who's from Colombia, and he published it while he was at Mayo. And they published the largest experience at the time of 170 patients with neuroendocrine liver metastasis. And the goal of resection at that time was at least 90% of the disease. And they achieved 96% symptom control, which was actually very long-lived for at least 3 years in the median population. And the overall survival for those patients at 5 years was 61%. So it was much better than what registries and population level data had shown. However, and this is very important, the 5-year recurrence of these patients was 85%. So very, very high recurrence, despite the fact that there was significant survival and symptom control benefits. So when we talk about resection beyond the symptom control issue, the question is, how much is it worth and how much are we going to be able to resect so that it actually impacts the benefits or benefits the patients? And of course, there's this case, for example, it's a 63-year-old patient that had two small lesions, on the right and the left. And I think there was a third lesion there. And these are relatively simple cases that it's clear that there's basically going to be a benefit in doing a complete resection. I showed some of the data before, and it's something that is not going to impact the patient from a huge operation or from anything else. And it just kind of makes sense from all the data that exists. This is another meta-analysis that showed basically comparing the survival benefits, comparing curative resection, which they classified R0 and R1 resections, compared to the bulking surgery or R2 resections. And you can see on the selected column in the middle that the 5-year survival on these patients was well over 70 or 80%. So clearly an outcome that we don't see with other types of treatments, and clearly an indication. And you can see here some of the forest plots and the benefits of R0/1 versus R2, the bulking resection. So whenever possible, we do go for a complete resection. But a few things that we need to understand is that, despite there's a clear benefit versus other therapies in the appropriately selected patients, this is unlikely to mean cure. The 5-year recurrent rate is very, very high. I mentioned the one by Sarmiento was 85% in a multi-institutional analysis that included close to 350 patients. The 5-year recurrence rate was 95%. So essentially everybody recurs. And what we tell patients is, this is not really a plan to cure you. It's more like an opportunity to reset the clock back, try maybe to be off all the therapies, prolong your survival, but the chances that this is going to come back are very, very high. And there's actually a pathology-based study that have looked at the surrounding tissue after liver resections, so complete liver resections, is showing that there's actually micrometastatic disease outside the index lesions. So then the next question is, well, when we can't do a complete resection, can we do cytoreduction? And the threshold of 90% was the typical threshold used. Also started with the idea or the paper that was published from Sarmiento from Mayo Clinic, in which that was the threshold used. And since then, many single center and multi-center studies had used that threshold to define which patients would benefit from this. And like I mentioned before, the 5-year survival was around 60%. You can look at this table here in which we have the the upper two studies were studies that were used, were published at the time in which that was kind of the threshold that was used. And you can see that the 5-year overall survival was in the order of 70 to 80%. And you can see 10-year survival rates of over 50% as well. However, back in around 2014, 2015, there are a couple of studies that were published using a 70% threshold. And you can see 4 or 5 of those studies listed in the table on the lower part. And you can see that the 5-year survival for these patients either stayed the same, and in some cases with more selected patients, it actually was up to 90%. So because of that, of all these retrospective studies, the pendulum has swung right now to do the bulking surgery or cytoreduction whenever we can achieve at least 70% of what the disease is in the liver. However, other factors likely are influential of the outcomes, and this is basically a guide in regards to the thresholds. But like I said before, there's multiple other things that you have to consider, and like Dr. Clark also mentioned for the PNETs, there's so many things that go into the decision of doing surgery that without really hard evidence of one way or another, you have to really consider all of these features of the tumor and of the patient before you proceed. It's important that when you think about doing a resection for the bulking and really encompassing or being able to include a larger pool of patients in this criteria, there's some techniques that you have to start using to be able to do that, basically accomplish that level of resection without removing the whole portion of the liver or a big portion of the liver. And that's what we call parenchyma sparing surgery, in which is basically associated with improved outcomes at the short term, also at the long term with recurrence not necessarily decreased, but with more options for recurrence management as you have more liver to work with. And this is a cartoon that showed what parenchyma sparing resection is. It's basically doing non-anatomical resections of the lesions as opposed to doing, for example, a right hepatectomy, in which when the patient has recurrence on the left lobe, you don't have as many options to treat. But there's also other prognostic factors that should be considered. This is a nomogram looking at survival, in which grade was one of the most important things. This is another nomogram looking at recurrence-free survival, looking at different other factors, grade, primary location, type of hepatectomy, and so forth. And this is basically a list of some of the things that we consider in addition to the table I showed at the beginning that really impact the decision, or not so much the decision, but the outcome and how you counsel patients when making a decision of going to surgery. I want to talk about 2 other indications. One is patients with large neuroendocrine liver metastases. We don't see this very often, but they are very symptomatic, and there is rarely a meaningful response that can either palliate the symptoms or really obtain minimal response from a cancer perspective. So in many times in these cases, surgery is really the only option. This is a patient, 57-year-old female, with an unknown primary and a neuroendocrine liver metastasis. You can see very large tumors, primarily on the right, but also on the left. For these, more complex surgeries, what we do is 3D reconstruction, and then we actually doing 3D printing of these tumors to counsel patients and do a better surgical planning. This is that same patient, and you can see the extent and the size and the weight of this resected tumor. However, a month later after surgery, she was doing great. She still has another lesion that we have to go after, but only the palliation was significant for this patient, and we believe that by being able to remove it, we're also able to accomplish some improved survival. And this has been shown when you compare anatomic resections to other non-anatomic resections, like in this study. And the last indication that I want to emphasize is something that we've been doing for a while at Moffitt, is basically integrating liver resection as a focused liver-directed therapy with other therapies. This applies to patients that, of course, are not meeting any other indications, but may have a lot of disease with focal progression localized to one single or 2 single spots in the liver. This is, for example, one of these patients. You can see the upper 3 images show that there's some lesions in multiple areas of the liver. And then in segment 7, in the lower part, the posterior part of the liver, there's just a small lesion. This patient had PRRT, And you can see on the lower images that the lesions across the liver were much smaller, but there was focal progression in that segment 7 lesion. And you can see that, this coronal view is similar. There was significant progression. We took this patient for a focus surgery only of that lesion. And we can see that it remained to be a well-differentiated neuroendocrine tumor, but the Ki-67 was now 24% when he was presented initially with a grade 1 tumor. So we looked at this. We looked at 69 patients with focal progression who had been previously treated and who we use basically focal targeted therapies. And this is not only surgery, but also other targeted therapies. And in 44% of these patients, the Ki-67 increased. And the outcome was actually relatively good. The overall survival was 97% at 2 years. And most importantly, the median time to actually new systemic therapy was almost a year and a half. So this also buys patients not only the opportunity to control more aggressive disease and potentially improve survival, but also come off systemic therapy that may affect the quality of life. Very important to understand that all of these procedures should be done in a center with expertise in neuroendocrine tumor care, where there is a lot of multidisciplinary approaches. From a surgical perspective, it should ideally be done in a high volume center where liver resections are done at least ideally, at least 50 a year, where there's predictable outcomes within national benchmarks, 90-day mortality less than 2 to 3%, and textbook outcomes of over 60%. So indications for surgery: complete resection, meaningful and safe cytoreduction with a 70% threshold, unifocal progression, and large tumors for palliation. But keep in mind always that there is a high recurrence, what the timing of what other therapies, what the role of all of these plays into the decision-making. Because these neuroendocrine tumors, I think, is the best example of the paradigm shift from cancer like we used to see it in the past to more as a management of a chronic disease. These patients are going to live many, many years, and you want to make sure that you do the right thing at the right time, in the right sequence, and consider all the relevant issues before you burn any bridges, because they will remain with disease and they will have disease come back, and you'll have to have new options and alternatives to treat them.
Dr. Anaya, we are out of time. Are we with a few slides?
No, I think that's it. I didn't get the sign, but basically I just wanted to emphasize that there's other considerations, including combined resections, intraoperative carcinoid crisis, and then other topics that due to the extent of the time that I allowed for the presentation, we don't have the time to go over. But I think I emphasize the key points. And once again, thank you so much. Muchas gracias, and it's been great to be part of this first Latin American NANETS meeting.
Thank you so much, Dr. Anaya, for this wonderful presentation. A lot of information, I know, but now we need to give the podium to Dr. Julie Hallett, and she's going to discuss the pros and cons of liver transplant. Thank you so much, Dr. Hallett.
Thank you very much, and thank you for the invitation. It's a great pleasure to participate in this first Latin America symposium. So I'll be talking quickly about liver transplant and try to assess whether it's a yay or a nay for neuroendocrine tumor liver metastases. So before I start, this is a virtual symposium, and I want to say that I'm talking to you from Toronto in Canada, which for thousands of years has been the land and the traditional land of the Huron-Wendat, the Seneca, and the Mississaugas of the Credit. And today it is still home to many Indigenous people from across Turtle Island. And we are grateful at the University of Toronto to have the opportunity to work on this land. These are my disclosures, though the most important one is probably that I am not a transplant surgeon. I'm a trained surgical oncologist specialized in hepatobiliary surgery with a focus on neuroendocrine tumors. So keep this in mind as it may tend to my observations or interpretation of the data. All right, so why a liver transplant for neuroendocrine tumor liver metastases? Like we talked about a lot today, neuroendocrine tumor care is, when we talk about metastatic disease, a lot about control. So controlling tumor volume, endocrine activity, and then somewhat local regional complications. But so the idea of removing the entire liver when it's packed with metastases is pretty enticing, because basically get rid of all of them and put in a brand new liver without any metastases. And that's helpful because the number one site, as we talked about a lot today, of metastases is liver, and often this is isolated or dominant disease within the liver. So that's how people start talking about liver transplant for neuroendocrine tumor liver mets. And I always like to go back to how it started to sort of understand what we all base our interpretation of data on. So the first team to report this was a team from Milan, from Dr. Mazzaferro, and they reported initially 9 liver transplants from 1987 to 1999. And those 9 liver transplants came from over 300 patients with metastatic neuroendocrine tumors, of which only 55 had been referred to surgery, which I would argue is not really what the standard of care would be these days. More patients should be assessed by specialized surgeons. And then of those, 26 were deemed unresectable, and then 9 had liver transplants. Subsequently, they did a prospective series, and this is all prior to 2006, so prior to modern systemic therapy for neuroendocrine. They report on 26 liver transplants in patients that were very highly selected. And within those patients reached a 5-year overall survival of 90% with disease-free survival of 77%. So again, highly selected and prior to sort of modern systemic therapy. From this experience, they put together the Milan criteria that now dictate selection for transplant in neuroendocrine tumor liver mets. And so here they are. The first one is need to confirm histology and note how dimension of carcinoid tumor, which I think speaks to the era when this was published. More recently, we've added a Ki-67 below 2% to 10% to this to sort of reflect modern classification of this disease. The primary tumor has to be drained by the portal system, sort of going to this idea that the liver mets are different than systemic metastases and they more behave like regional disease, hence transplant being a good idea. And the primary has to be completely removed and there has to be no extrahepatic disease. There has to be less than 50% replacement of the liver parenchyma with tumor. The tumor has to be stable for at least 6 months and only in patients less than 55 years. So that's how it was initially described. Now, a lot of other centers have reported their experience since then. What we get from that literature, it's mostly very heterogeneous selection in terms of who gets evaluated for liver transplant and who receives it. There is still early and frequent recurrence within the grafted liver or extrahepatic. And there is in particular no assessment of patient-reported outcomes or quality of life in those retrospective studies, which we know for chronic cancer is quite important as for neuroendocrine tumors. With this, there is a wide range of long-term outcomes, but overall, 5-year overall survival is around 50% and 5-year disease-free survival around 30% in reported experiences. Now, how does it fare versus other therapies? So when we take all other therapies together, so resection, but also TACE, bland embolization, PRRT, we have very little data to look at, mostly outdated retrospective series, but those do not report any significant differences in outcomes despite the inherent selection bias. What about liver resection? Again, small series, often single center. But in general, when we put this all in a meta-analysis, there was no difference in overall survival, so no definitive benefit for transplant. However, there was a higher disease-free survival for the transplant group compared to liver resection. So the important thing with the data I just mentioned here is that this all came before contemporary management of neuroendocrine tumor metastases. So at a time where we really had few tools in the NANETS toolbox, these days I think that though we're adding more and more, that toolbox is very well stocked. And so it's a different landscape in which transplant may have a role to play. And really, there's been no assessment of where it fits in sequencing of therapy or where it fits in combination with other therapies, which is a big gap in assessing its role. So all that being said, does it mean that transplant is for everybody? Nobody, some people. How do we select who is eligible and when they become eligible for it? So I'll start with this algorithm that came out of a recent meta-analysis on the topic. And so we'll focus on the section of the algorithm where the transplant comes into play. So you see it's in a grade 1 and 2 lesions, so well-differentiated, low Ki-67, good biology lesions. And the first note in that this is in liver metastases that are unresectable. So what does unresectable means exactly, and how many patients would fit in there and be selected to go down a potential transplant path? Well, I think, and Dr. and I alluded to this, it depends on what you do. So in neuroendocrine tumor liver mets, we focus on parenchymal sparing resection and try to avoid anatomical resection. So our group does not perform anatomical for neuroendocrine tumor liver mets. We don't do right hepatectomy, trisegmentectomy. We go exclusively with parenchymal sparing resection. Reason behind it is that what we see in the OR and on imaging is only the tip of the iceberg. There is always way more tumors, and we do not believe that there is such a thing as R0 resection for neuroendocrine tumor liver mets. That this is probably a utopia, and really what we aim for is an R1 and R2 resection, so a cytoreduction, like a lot of people call it. And how do we achieve this? It's by doing these enucleations that take advantage of the fact that the liver mets push rather than invade into the liver parenchyma. So we can enucleate one lesion at a time, takes a lot of patience. We can do this for 1, 5, 10, 55 lesions, as many as needed, and often even along major intrahepatic structures. This can also be done for very large tumors, like you can see right here, and it is effective in saving parenchyma. This is data from one of my surgical partners, Dr. Law, and he looked at liver volumetry of the normal parenchyma before and after enucleation and debulking, and was able to save up to 73% of the parenchyma, even with very large volume debulking. So all that to say that when we talk about unresectable, if something cannot be resected with anatomical resection, it does not mean it is unresectable. And the unresectability has to be assessed by specialized neuroendocrine tumor liver surgeons. So if we go to the types of liver mets that we can find in neuroendocrine, this is as described by Andrea Frilling from the UK. With the type 1 and type 2s you see here, those can be resectable with parenchymal sparing approaches by experienced surgeons. The type 3 are the ones that are most often unresectable. And in that setting, just keep this in mind, over 50% tumor load is pretty much what always happens in type 3, as you can see by the image here. Okay, so we look at, first they have to be unresectable, but I guess my point is that often patients who are unresectable have over 50% tumor volume within the liver. The next criteria is the patients have to meet Milan criteria. So let's look at those Milan criteria in more details. How many patients would meet those criteria once deemed unresectable? So histology below 10%, well differentiated, a lot of people would meet that criteria. Primary portal drainage, that takes out a lot of lesions and a lot of primaries, and there is a debate about whether the pancreas has portal drainage or not, so whether it is eligible for transplant or not. Less than 50% tumor replacement in the liver, like I just talked about. Once you're deemed unresectable, it's likely there's over 50% replacement, so we lose a lot of patients here. No extrahepatic disease, resecting the primary, I think that can be done often, so that's good. Less than 55 years old, a lot of patients won't be eligible here. A lot of our patients are over 55. What about stability for over 6 months? That's kind of a tough criteria. So in my mind, if tumor is stable for 6 months or 12 months, like we can pick any number, it's, you know, we face one of two scenarios here. Either we have very long-standing stable disease, which happens often in neuroendocrine, and we know that can last for years. And at that point, why change management? Why add a liver transplant to this if we don't know there's clear benefits in overall survival? Just continue with the treatment you have and spare lines of therapies for down the road. Well, then if we do that, we end up with those patients with rapidly progressive disease, and often in those patients, why would we do a liver transplant? That's a difficult question, because maybe the biology is not favorable to receive a transplant in this setting. So really for this question, the jury is still out, and nobody really knows, and we don't have good data, but those are some of the thoughts that we can go for. So those for Milan criteria. So once you're unresectable, really, very few people will actually meet Milan criteria. Well, then should we go out of Milan and transplant patients outside of those criteria? It happens in quite a number of centers and internationally. Up to 46% of liver transplants reported for neuroendocrine tumor liver mets in the literature are done outside of Milan. The criteria most people go out of are the age criteria, the disease-free and like the stability interval goes up to 12 months. And the portal drainage, people will transplant without necessarily proving portal drainage. The ones that are most commonly followed are the Ki-67 below 10% and well-differentiated histology, and the no extrahepatic disease. But in a recent series from Annals of Surgery, they have over 705 transplants in there, and overall survival is drastically reduced when patients are transplanted outside of Milan versus within Milan. And also when they're transplanted outside of Milan, their outcomes are not favorably compared to the patients who receive other non-transplant therapies. So all that being said, who can we select for transplant and when can they be selected for transplant? Well, what I was trying to show you is that most unresectable patients will fall out of Milan criteria so long as they've been deemed unresectable by experienced neuroendocrine tumor liver surgeons. When we transplant out of Milan, we have worse outcomes, and those do not compete favorably with other available therapies. And during the discussion, if people want, we can talk about challenges related to primary resection, extrahepatic disease management. So this is where I really struggle. Where is the sweet spot for transplant in liver and neuroendocrine? At the very beginning, there's still lots of unknown. We don't know what the disease biology is going to be like, how patients are going to be. And so it's probably too early to transplant. At the very end, when the disease progresses quickly and patients are close to death, it's too late. And in the middle, we have this sort of maintenance therapy or disease control under therapy, as mentioned here. And we know from experience that in neuroendocrine, we can keep that going for years with different lines of therapies, trying to spare those therapies over time to bring the patient the furthest we can. And if it's stable and it's plateauing, why push a liver transplant with lots of morbidity and somewhat unknown outcomes with sequencing of other therapies? So the approach that my center has taken is those are the patients we consider for transplant, and that's very few every year, despite having one of the largest volumes in Canada. These will be very young patients that have favorable biology, deemed undebulkable by neuroendocrine tumor liver surgeons, and those that are very, very, very functional. So where there's a big endocrine component, and no matter what we do, no matter what therapies, patients are severely impacted by it, and it becomes a quality of life issue. And in those settings where we cannot control that, those are the ones we've sent for transplant. There's some thoughts also now about salvage after other therapies. So once we've already gone through embolization, through resection, through systemic, whether transplant could be discussed there, but that will warrant a change of selection criteria. So where are we heading? In the future, we'll need to better define the role of transplant with other therapies and the timing and sequencing, review the selection criteria, also get long-term follow-up data beyond 5 years. And I'm just going to finish on this, looking at what's being done right now. This is the one prospective study that's ongoing. It's in the UK and Ireland, and they have a multi-centric national registry where they plan to transplant 50 patients over 5 years, initially within Milan in the phase 1, which you see right here. And then once they've transplanted and have good outcomes in audits of morbidity, mortality, and recurrence, they plan to expand beyond Milan and see how those patients are doing. And this is all managed by like a single body that's legislating all of this. So in summary, there's probably a small subgroup of patients who may benefit from liver transplant, although we don't have any definitive evidence of its benefit over other therapies. When you have access to specialized neuroendocrine care and surgery, very few patients who are really unresectable will be eligible for liver transplant. And as we move forward, I would say that we really need to develop new selection criteria, and that should be led by neuroendocrine experts in collaboration with transplant oncology, because traditionally this has been done by transplant surgeons, and of course the viewpoints can be quite different. So liver transplant for neuroendocrine tumor liver metastases, for me, it's more of a nay, and there might be a small yay, like a little open window that we can look at in the future to see if it's safe to open it further. With that, I'll thank you very much for your attention and look forward to the question period. Thank you.
Thank you so much, Dr. Khaled, for a fantastic, excellent presentation. Now we have Dr. Suarez, who's going to discuss with us the role of neoadjuvant or adjuvant therapy in neuroendocrine tumors. Dr. Suarez.
Dr. Suarez, you might be muted.
You know, it never gets old, right? All right, I mean, you guys see my full screen?
Yeah, we can see your
Okay,
screen.
all right.
We don't see you, but we see your screen.
Oh, you don't see me either. All right, sorry, thank you. So thanks for having me. It's a pleasure to be here with you all. And with that, these are my disclosures. And then the first thing is to stop and think, why are we even talking about neoadjuvant and adjuvant therapies? Why do we need to talk about perioperative strategies? Well, for many reasons, including that if we look at the data that has been presented by Dr. Dasari and colleagues from 2017, there is an increase. We know that there is an increase of the incidence and prevalences of neuroendocrine tumors. But what is most interesting is that the increase is actually disproportionately higher in patients with local regional disease. So even though most of the patients are still diagnosed at the time that they have metastatic disease, we're seeing an increase of patients with localized disease. And then we look at the patients that go for resection. What is the risk for recurrence after resection? And this is data from Canada and from this study that was led by Dr. Simran Singh. And you can see that there's a large portion of patients that after the resection of their GI tumors, they will recur. And you can look in the graph and see that pancreatic neuroendocrine tumors have a higher rate of recurrence, and then they can take a long time to actually recur. Yeah, some tumors can take up to 10, 15 years to recur, but there's a good portion of patients that unfortunately will have recurrence in the initial 3 to 5 years. When we take a look in a different cohort of patients, this is a cohort from Moffitt that was done by Dr. Shivis and Dr. Strasberg, and they look at retrospective at 129 patients with mid-cut NANETS. And here they reported that 40 patients or actually did suffer recurrence with a median follow-up of 81 months. And then some of these patients, took a while, but eventually they recurred, as you can see in the graph. When we look at the data from the US neuroendocrine tumor study group, that is a group that developed a database, including patients with neuroendocrine tumors from the GI tract from 8 academic institutions in the US. You can see here that, again, the curves that show the recurrence rate of these patients. Many patients will have recurrence locally in the pancreas, and many patients will have a liver-only recurrence, and many will have combined. And most of, a good majority of these patients will actually recur in the first 48 months. And the median overall survival, the median recurrence-free survival for these patients was 20 months. They also had several publications that look into the risk factors or predictor factors for recurrence, and positive lymph nodes or DAF41 that you can see in this graph. R0 versus R1 resection was found to be significantly statistically different when they look at long term, but you can see that many patients actually will take a long time for this to happen. And one of the most recent analyses that they look at was trying to develop a predictive score. And they developed this predictor score on a point system, and patients were considered high risk if they have a point system of 6 points or more. And in a nutshell, a high recurrence predictive score is essentially related to patients that had the primary tumor resected, and the Ki-67 of these tumors was above 20%, or they were G3 well-differentiated tumors. And they saw that for patients in such situation, the recurrence rate was 32% in 2 years. when we brainstorm about this and we discuss in the community whether or not, this early recurrence will impact survival, up to recently, we didn't have a lot of data, but the US NANETS study group actually published their results and show that, yes, there is a difference in survival, their database in patients that recurrence versus the ones that do not have recurrence. Dr. Anaya and Dr. Hallett already mentioned the fact that even if you have a resected liver lesion, even if you think you remove all the tumors, they are expected to come back, and the local recurrence can be, depending on the literature that you cite, up to 94% in 5 years. So even if you think you have a full resection of your primary tumor and all the liver mets, these patients will likely recurrence. And you can see here some of the impacts in survival. There's other factors that are coming up as potentially predictors of recurrence. And since Dr. Thor is going to be giving a talk about this, I'm going to skip that, but just want you to all be aware that there are more studies coming out in trying to understand if in the molecular level we can predict who is at high risk for recurrence, particularly in pancreatic neuroendocrine tumors. So would perioperative therapies improve outcomes, and why we should do that? Well, as in any other disease, the goal is to reduce tumor size, disease burden, and hopefully make the disease suitable for curative surgery, and also even if the disease could be potentially upfront resected, eliminate micrometastatic disease before, if you're thinking about the neoadjuvant setting, or after if you're thinking of the adjuvant setting. And several studies have indeed looked into the impact of perioperative therapy in the patient outcomes, but no randomized studies exist which demonstrate a benefit of neoadjuvant and adjuvant strategies. So let's just do a quick diving in the neoadjuvant studies that are out there. Several years ago, the MD Anderson published their experience with cytotoxic chemotherapy, with FAS, which is fluorouracil, doxorubicin, and streptozotocin, and they look in patients that had exclusively pancreatic neuroendocrine tumors that were localized, and they also look into patients that had tumors with also disease in the liver. And in general, they show that patients who have a response, but in the localized tumors, the response rate was about 7%, and only of the patients that were studied, actually, only 21% of these patients were benefits to the point that had reduction of the primary tumor vascularity that consequently could lead to a resection. And in the metastatic setting, the activity of this chemotherapy regimen was a little bit better. Here, they just look into the overall survival on A versus the recurrence-free survival. Even though in the top, you see that there is no difference when you look in the bottom of the slides for patients that had a synchronous pancreatic neuroendocrine tumor with the liver mets, and they were resected after receiving the chemotherapy, they felt that there was a benefit. I should mention to you that this is a small number of patients. If you see here, we're talking about plus or minus 20 patients in each group. Okay, and then here is just to show overall survival. They argue here that you might have a benefit in survival for patients that receive this approach. Then we can talk about CAPE-10, right? We know, thanks to the ECOG 2020 11 that was led by Dr. Coombs, that CAPE-10 show a benefit in the metastatic well-differentiated pancreatic neuroendocrine tumor setting. And before that study was published, there was already a lot of small studies and case single patient groups that show that patients could respond extremely well to CAPE-10. So this was a study that was looking to 30 patients with local advanced PNETs, plus or minus with liver mets that received CAPE-10. And you can see that the response rates were about, the partial response rates were about 42%, which if you look into comparison with the metastatic data that we know now, it was 39.7%. Then you can think about other strategies, right? If we're not doing chemotherapy, what else can we do? Can we use PRT in the neoadjuvant setting? Well, this was a study that was performed in India that showed the feasibility of PRT. And then patients that had localized and resectable GAP-NETs, they were with or without liver mets, then they received lutetium dotatate PRT up to actually 5 cycles over there. And then they reported that 26.3% of the patients actually became resectable, showing that could be a safe modality to be considered. And this is just an example of the response that I saw on A. You can see the dotatate PET scan. They also got FDG PET on B. And then after the treatment, you can see the nice response. And this patient actually underwent resection of her pancreas and liver tumors. Another study from Italy shows that patients that receive PRT upfront, they had longer progression-free survival. And you should just be aware that this is a very small sample size, but there are several studies that are coming up suggesting that there might be the benefit as well. Then we look at this registry database, a national database that was done in trying to collect this data. And you can see here, when you look at all the population, there is no difference. When we look at B, I'm sorry, at A, when they match the cohort to make sure that the patients that receive adjuvant treatment were actually matched with the patients that went to surgery up front, there was perhaps a suggestion that the benefit of the surgery alone, which is interesting. And then when we look at the neoadjuvant strategies here, there was no difference, which is in the bottom C and D. A meta-analysis was recently published looking at studies that have investigated neoadjuvant therapies. 9 studies were identified here, distribution between PRT, chemotherapy, PRT with chemotherapy and sunitinib, which is a TKI, as you know. When you look at the table, we see that the chemotherapy regimens and PRT can get a response rate, typically about 40%, particular CAPE-10, which was 41.5%, and PRT was 47.5%. When we look at resection rates, the patients that received chemotherapy had overall 79.3%. If you look only at CAPE-10, was 88.5% of resection rate, and with PRT here was 65%. What about adjuvant studies? It's a little bit harder to find adjuvant data. There is this study that was actually done at Louisiana at the Osler Clinic. They're looking to membrane with 5-FU to be placed at the site of the resection for patients that had midgut tumors with extensive mesenteric lymphadenopathy. And the survival curves are here. And you can see that there was no difference in terms of survival. Then there are some adjuvant retrospective data that also has been published by the US Neuroendocrine Tumor Study Group. They're looking to their database, and they found that out of the 1,662 patients with stage 1 to 3, 91 patients received adjuvant treatment, and most of them did not. And I put the little red mark there because all the patients that received adjuvant treatment in general had features that suggested the tumors were more aggressive. And when you look at here, you clearly see that the recurrence-free survival of the patients that receive adjuvant treatment were lower, with 49% in 5 years versus the no-adjuvant treatment, which was 81%. Again, you can argue that this is a match analysis, and that the patients that did receive adjuvant treatment, because this was a retrospective data analysis, were the ones that had a higher risk for recurrence anyway, and then the physicians were just trying to avoid that or decrease the odds of recurrence. Here, just another way to exemplify there, a small number of patients. This is another study that was done in France, looking at adjuvant chemotherapy with streptozotocin and 5-FU. And in this study, 61% of the patients had small bowel tumors in the observation, receive it. And you can see that they were pretty similar in terms of recurrence-free survivals in the patients, as well as overall survival. And again, the number of patients is small. In the chemotherapy group was 29 patients versus the observation group that was 23 patients. In China, there was a study that was presented at NANETS and recently published in 2020 that looked into the role of adjuvant somatostatin analogs with octreotide for 6 to 12 months post-resection of G2 PNETs. And here you can see their initial reports, but actually when they adjust for all the confounders, the only time that they saw a statistically significant difference was that disease-free survival at 3 years. And the overall survival for the groups when they adjusted was actually the same. So there was no difference. And you can see the graphs towards the end here. There have been some attempted trials that have been started in the perioperative setting. One study was looking into patients receiving PRRT after the resection of their tumors. The study was closed due to lack of accrual. There was also a study that was NCCT study here in the United States, trying to evaluate the role of adjuvant everolimus following the resection of metastatic pancreatic neuroendocrine tumors to the liver. Unfortunately, this study also was closed early to accrual due to lack of enrollment. And there was this mention of this single prospective arm study of PRRT prior to liver transplantation that we don't have any updates, and the study, I think, has been probably abandoned. So with the final data and the presentation of the ECOG 2211 that shows the efficacy of capecitabine and temozolomide in patients with pancreatic metastatic neuroendocrine tumors, is there a role to, now that we have this validated treatment, to try to investigate this in the adjuvant setting? Shall we test this in the adjuvant setting? Before we go there, for now, what I can tell you, what's the take-home message here? Routine use of perioperative therapies in GI should not be considered standard of care. And on occasion, after discussion with your multidisciplinary team. And again, that's why it's so important to have a huge care team that specializes in NANETS, taking care of these patients. And none of the current guidelines strongly advocate for the perioperative treatment. And I'm here mainly talking about the well-differentiated GAP NANETS. We didn't touch in lung because the session was about GI. But we're seeing more and more of these cases with patients with local regional disease. And here I'm just going to show a real case to you. A 47-year-old patient with no prior medical history presents to the ER with abdominal pain. MRI shows large pancreas mass in the tail and few liver mets, one of them rather large. US showed the mass in the tail that was measuring 6.5 centimeters with invasion of the splenic artery and splenic vein that was encasing. IFNA was done and showed a well-differentiated neuroendocrine tumor, grade 2 with a Ki-67 of 4%. So I know for the surgeons, I'm not giving enough information in the imaging, so you have to Trust me on that. There was a big discussion at our tumor board in what to do with this patient. You know, do we start with a somatostin analog to see the biology of the disease? Do we do some sort of neoadjuvant treatment? Do we go straight to surgery, right? And I'm sure that if you ask 3 different or 5 different people in the audience, many will have very different ways of approaching this. And I would love to see later when we go to the discussion what my colleagues will have done. So actually the patient, for this particular patient, underwent an upfront resection, and following that he enrolled on the SWOG 2107 adjuvant therapy. So what is this adjuvant therapy study that we're talking about? Well, this is a study exactly to look at the role at capecitabine and temozolomide in the adjuvant setting in patients with resected pancreatic neuroendocrine tumors. They have high-risk features for recurrence, and I'll touch what they are here. Patients are randomized on a 1-to-1 fashion to receive CAP10 for 4 months versus observations. Patients are scanned in the initial 3 years every 6 months, and after that every year for a total of 6 years. And the primary endpoint of the study is the 3 years recurrence-free survival, because if you remember from the beginning, we see that there's many patients that will recur in the first 3 to 4 years. In terms of the eligibility, what is considered high risk? There's a score system that was validated on the US neuroendocrine tumor group that look into the Ki-67, a pancreas tumor that's more than 2 centimeters in size, positive lymph nodes, and any symptoms of presentation. And again, if a tumor has a Ki-67 more than 20%, then automatically it's scored as a high risk. These are some of the other eligibility criteria. And I would like to share that this is a big effort from the SWOG team and the NCTN and all the cooperative groups. And right now the trial has enrolled 12 patients, and we hope that we'll continue to enroll. And we are trying to see if there's a way to open this trial in Latin America and work with our collaborators with Latin America. I know that there is some issues with temozolomide availability in Latin America, but there are conversations going on to see if that will be feasible in particular sites or countries. Obrigada. Thank you so much for having me.
Okay, thank you so much, Dr. Suarez, for an excellent presentation. So we actually run out of time, but the NANETS team allowed me to just a very quick questions. And if you could be so kind, our surgeons, to answer very quickly. And I'm sorry that we run out of time, but this is a question from Dr. Roman. And he said that, first of all, beautiful talks. And he said that he has a patient with liver metastases from grade 1, well-differentiated neuroendocrine tumor. So the plan is to retreat with Lutathera. However, his surgeon is recommending to resect some of the larger liver mets. He still believes that there is some microscopic disease in both sides of the liver, both lobes of the liver. So his question is, when the timing of PRRT before or after surgery. So maybe that will be a question for Dr. Suarez, and maybe you can answer quickly, if that's okay.
I'm sorry, I was reading the other question. If someone can jump in for me first.
Of course. I think maybe what I would suggest is it's all about sequencing and sparing therapies over time, right? This patient is going to need multiple lines of therapies. If the disease is liver dominant, we tend to go ahead with liver surgery first. So we'll debulk the liver to as low as possible, knowing it's R2 and there's remaining disease that can likely be controlled with somatostatin analogs. And then we monitor them. And upon progression, which is expected, as we talked about, then we would trigger other lines of therapies. And so we would reserve PRRT in patients who are potentially debulkable with reserve PRRT for later down the road, not to use all of our munitions up front. Also knowing that with PRRT, if there's liver disease, there is a theoretical risk of fibrosis within the liver, which may preclude liver resection in the future. So again, one of the rules of sequencing is not to preclude future therapies and the toxicity of what we're giving at the beginning. So we start with surgery when we can and reserve PRT and other lines for later on.
Great. Well, excellent answer. And that's unfortunately all the time that we have. So we need to move to our next speaker. And I would like to thank you, all of the speakers from this session. It's now time to transition to overview of precision medicine and neuroendocrine tumors. Are we ready for prime time? Thank you so much for your attention.
Good afternoon, everybody, and thank you very much for continuing in this very important initiative. Our speaker for this session is Dr. Thorvaldur Halldanarsson, Professor of Oncology at Mayo Clinic in Minnesota. He currently serves as the Vice President for the NANETS, and he has been a great supporter of this initiative. I remember 5 months ago when I contacted him, he replied to me in a matter of 10 seconds saying, yes, he will participate of this event. And for the knowledge of this audience, and please correct me if I am wrong, today is his birthday. So thank you very much for giving us part of your birthday time and for celebrating your birthday with us. Thank you.
Hello, I'd like to, hopefully you can hear me. So I'd like to thank you for the opportunity to speak, and what better thing to spend a birthday than with my other family, my neuroendocrine tumor family. So let's dive into it. So I was given a talk of precision medicine and neuroendocrine tumors. Is it ready for prime time? And let's see if it is. So here are some of my all of my disclosures. I tend to be inclusive there. And this is the overview. So first, I was going to talk about some definitions, then break it down to the genomics of well-differentiated neuroendocrine tumors and poorly differentiated neuroendocrine carcinoma, and how we can identify targets and move the field forward. And if time allows, I'll get into radiogenomics and selection of patients for systemic radiotherapy, possibly also talking about the prediction of hematologic toxicities. So let's start with some definitions. So obviously, I was given a task to speak about precision medicine, so I naturally Googled precision medicine. I should actually have asked the chatbot about writing me a definition, but I didn't. So this is from the NCI. So this is a form of medicine that uses information about person's own genes or proteins to prevent, diagnose, or treat disease. In cancer, precision medicine uses specific information about person's tumor to help make a diagnosis, plan treatment, find out how treatment is working, or make a prognosis. So I also went to the NIH, the National Human Genome Research Institute, and they have a very similar definition of precision medicine, essentially an approach that uses information about individuals' genomic, environmental, and lifestyle to guide decisions related to the medical management. So as you can see, pretty broad definition. So how will this apply to neuroendocrine neoplasms, or NENS? I guess the typical application would be we identify a molecular target, let's say a mutation or a fusion. We pick a drug that targets that fusion and we give it, hopefully with good results. But as per the definitions before, we're not quite there with NETs, but we're getting there. So precision medicine may also apply to situations other than choosing the right therapy. Maybe prognosticating, finding out the outcomes after surgery or any other intervention, help select treatments not to give, and even identify toxicity. And just because we're on the topic of precision medicine, well, someone said analog therapy and PRT, or any someone-said directed therapy, is really precision medicine. We identify a target and we hit it. So here are the therapeutic levels of evidence, and this is really one of my favorite websites in oncology. If you haven't checked out OncoKP, you should. So this lists the levels of evidence at the top when we have an FDA-recognized biomarker predictive of a response to an FDA-approved drug for that particular indication. Well, where do we live, the neuroendocrine folks? We live here at the bottom, so evidence level 3B and 4. So we're standard of care testing, we're investigational biomarkers, can sometimes direct us to use FDA-approved drugs, but typically for another indication. Or more commonly, probably, there's compelling biochemical or biological evidence to use that marker to select a certain therapy. So that's where we are. So moving on to the genomics of well-differentiated neuroendocrine tumors, because that's the bulk of what we see. So the genomics of well-differentiated NETs, especially small bowel NETs, have been known for a while. So older studies suggested that these are pretty dull tumors when it comes to genomics. They have a low mutation rate, rarely actionable alterations. There are somatic copy number alterations. There are mutations in CDKN1B, CDKN2C, B core, and these are not targetable with any of the drugs we have right now. And then there are epigenetic alterations. But more recent studies have actually suggested that these tumors are a little bit more lively than that. So there are driver mutations, maybe up to 50%, but they are mostly tumor suppressor genes, which are hard to target, TP53, RP1, and others. And then we know that these mutations go up with higher tumor grade, and there are potentially targetable alterations in up to a quarter, or probably not, up to a fifth of the metastatic small bowel NETs, like RAS, MEK, RET, and others. And then we know that we can group these tumors into certain subgroups and predict outcomes that way. And lastly, everyone wants to know about mismatch repair deficiency and TMB. That's typically rare, and tumor mutational burden is low in small bowel NETs. So what about immune markers? So this is a study from Caris looking at what I call a mixed bag of low-grade neuroendocrine tumors. Didn't provide much information on the characteristics of the tumors in terms of differentiation, but I assume that all of the low-grade tumors, which are the yellow bars, are well differentiated. So as you can see, PD-L1 less than 2%. DNMR actually not seen in this cohort, and it's a sizable study. And then tumor mutational load, which in this study was defined as more than, there's a typo there, more than 17 mutations per megabase. Actually pretty uncommon, 1%. Actually higher in high-grade tumors, almost 7%. Another study looking at TMB in rare tumors had neuroendocrine neoplasm cohort, but we don't really know what these are. Are these NETs, or are these NECs, or is it a mix? And in this study, a third of patients had TMB more than 10, but one wonders how many of them actually had temozolomide before, and which induces a hypermutated state. So we'll get more into the markers of immunotherapy a little bit later. So let's zoom in on pancreatic NETs and genetic alterations and revisit a very classic paper from 2011. So in that paper, it was shown that alterations in pancreatic NETs are very common, typically in MEN1, DAX, and ATRX, but also in genes of the mTOR pathway. And if you look at the right column, the PDAC, which is pancreatic ductal adenocarcinoma, it's very different from pancreatic ductal adenocarcinoma. Typically is KRAS mutated, TP53 mutated, while the pancreatic NETs are not. So these are obviously very different tumors, but we've known that for a long time. So what about those ATRX and DAX mutations? They keep coming up, and they actually are prognostic, but the prognostic value may depend on the stage. So in several studies, it's been shown that if you have a mutated ATRX or DAX or immunochemistry negative, suggesting a loss of the protein, the risk of recurrence is actually much higher. You can see the disease-free survival curves here. Top curve is wild type, bottom curve is mutated, the ATRX and DAX, and there's a big difference. Interestingly, some studies also suggested that this was the reverse in metastatic disease, where actually now it was good to have ATRX and DAX mutations, but later studies, including from the RADIANT cohorts, don't really support that. So I'm not sure if we should put much value on ATRX and DAX mutations in metastatic disease, but in early stage disease, it certainly seems to have some value. So how can we look at ATRX and DAX mutations? So we can do NGS, it's costly, takes time. We can do immunohistochemistry, but that's a little tricky to do. These stains are hard to read and not available. But there is a shortcut to the answer. So alternative lengthening of telomeres, or what I sometimes call the other ALT, is a FISH test. ALT is strongly associated with ATRX and DAX mutations, and those, as I said, in early stage disease are strongly associated with outcomes. So in this large study, several hundred patients, all with resected pancreatic neuroendocrine tumors, they had ALT done, and if they were ALT negative, you can see the green curve at the top there, they were not very likely to recur. As you can see, about 20–25% of them eventually recurred, while if you were ALT positive, indicating ATRX or DAX mutations, you were much more likely to have a recurrence. Well, in this cohort, they were also resected the PNETs less than 2 centimeters, but as we heard in previous talks, that's probably something we shouldn't be doing anyway, but they reported on that. And this also held true for small nets. And one wonders, should we use this when we decide on whether we should observe or operate small pancreatic nets less than 2 centimeters? Maybe we can run this on small biopsy materials, and that's actually been shown you can do that. So I could think of a situation where we have a PNET to 1.8 centimeters low grade, and if it's ALT negative, we might be less aggressive with imaging and interventions. But that I think needs to be studied better. So moving on to another classic paper, this is the paper in Nature by Alto Scarpa and his team looking at pancreatic nets and core pathways. So pancreatic nets have a larger than expected number of germline mutations. Listed there 4 main pathways of alterations: chromatin remodeling, DNA damage repair, mTOR signaling, and telomere maintenance. And if you look at the picture there on the right-hand side, there is not a whole lot of genes that are potentially actionable. Well, CHEK2 and BRCA we could possibly hit with PARP inhibitors, and then the TSC mutations with mTOR, but we're using mTOR inhibitors already in this disease. And the data on genetic selection or genomic selection of patients for mTOR inhibitor isn't that strong. So, but obviously, as time goes on, we'll have, I think we'll have better treatments and more options. Well, let's move on to MGMT. So we heard a little bit about MGMT and temozolomide. So temozolomide is an alkylator causes DNA mismatch and tumor cell death. We know temozolomide is active in pancreatic nets, and we know that the MGMT is a crucial enzyme for genome stability, and we know that high MGMT expression counteracts the effects of temozolomide. So it's been shown in glioblastoma that MGMT status is predictive of response and prognostic of survival. But what about PNETs? The literature has been really mixed. And it wasn't really until this study, ECOG 2211, we got good prospective data. So just to remind you, this was a randomized phase 2 study, 144 patients randomized to either CATEM or temozolomide alone. And here you can see the endpoints on the right side, but what we're going to be looking at is the MGMT analysis. But we can't really move on without looking at the actual survival analysis. So the study met its primary endpoint, at an interim analysis showing improved progression-free survival, not much difference in overall survival, which likely reflects the post-progression therapy. And response rates were similar in the 2 groups, slightly higher in the CATEM group, almost 40%, but not statistically significant. So what about the MGMT? So if you look at those patients who actually had a response, we can see that 52% of them had low IHC, indicating MGMT deficiency. And 85% of the small cohort tested with methylation assays had promoter methylation. So we can see there's some signal there. And if you look at the non-responders, most of them had high IHC for MGMT, and 62% of them had negative promoter methylation. Where it gets a little complicated is that if you look at these responders with negative methylation, actually almost 40% of them had that. So not sure where this really fits in yet, possibly if we need to select patients where we really need the response. But I wouldn't say this is ready for prime time. Well, let's talk about another test, the NET test. We can't do a talk without mentioning the NET test. So it's a multi-omics blood marker, definitely better than chromogranin, but that's a pretty low bar. Pretty much everything is better than chromogranin. And there is some potential use following resection. And there were 2 studies that looked at the neuroendocrine tumor patients who had resection and all had the positive NET test before surgery. So NET test done 30 days after resection of the neuroendocrine tumor predicted recurrences with very high accuracy. And look at these curves from these 2 different studies. So the top curve, the blue curve, are those with NET test 20 or less. So that's a negative NET test. And they don't recur in this relatively short follow-up of 2 to 3 years. But if you look at the red lines, these are the positive NET tests. We see a lot of recurrences there. So this, I think, is too good to be true. I think the test performs, but I can't imagine it performs this well. So I'm using this in my clinic fairly routinely now, but I think it needs to be better validated. And I think the SWOG study Dr. Suarez mentioned is building this in to the trial. So I've already tested probably about 40 to 50 postoperative patients. Almost all of them fall outside of the 20 or the normal range with a net test above 20, yet no one has yet recurred. So I'm not quite sure what to make of this. And then I've had a few patients who had active disease with a negative test. And I think the test is probably good, but probably not as good as this study shows. So moving on to predicting the origin of the tumor. So we know that certain tumors respond better to certain therapies. So small bowel NETs are treated differently than pancreatic NETs. What about those unknown primary NETs? Can we find out where they came from and treat according to those results? And we know that about 12% of advanced NETs have no known primary tumor. So there is a methylation profiling called NET-ID that predicts the origin of known NET primaries with 95% accuracy, but whether that holds up in unknown primaries is not known. But this is an interesting study from last year, and you can see how in two different data sets, how the lung NETs clustered together, the pancreatic NETs clustered together, and the small bowel NETs clustered together. So one could easily think of using this for unknown primary tumors, predicting the origin and then treating them accordingly. So to summarize the low-grade NET stuff we just talked about, so as for NGS of NETs, truly actionable alterations are uncommon, but there's probably going to be increased future role with more targeted drugs and markers predictive of immunotherapy, don't really help much. ALT, ready for use yet? Definitely correlates strongly with the recurrence risk after surgery. It's a simple probe. It's not available yet. Once it becomes available, I think I will start using this routinely. I think we have strong enough data for that. MGMT, is that ready for routine use? I don't really think so. There have been some methodological concerns, IHC versus methylation assays. There's definitely a correlation with the response rates, and possibly use there if you really need the high response rate, you might consider MGMT assay, but I don't think I will include that in my clinic yet. So lastly, the NET test post-op, strong association with recurrence. I think it's reasonable to use this, being mindful of the caveats and possibly performance issues, as I said. I think this really truly should be built into studies as well. Ideally testing this in independent cohorts from what has previously been done. Okay, so let's switch gears to poorly differentiated neuroendocrine carcinoma. Not really target rich, but we're getting there too. They're not target poor either. And here I'm going to try to make the argument for NGS for everyone. So this is one of my patients, a young person with metastatic neuroendocrine carcinoma, probably a large cell carcinoma of the lung, but we don't know. And she had brain metastases and bone metastases and extensive nodal metastases, and she had not started any therapy, but her primary oncologist ran genomics, and she had a RET fusion. And so we started pralsetinib, and within months, all of the disease went away, including all of the brain mets. So here this is now probably about 18 months in, and no evidence of tumor progression. So here, the application of genomic testing absolutely helped. She has not seen a drop of conventional chemotherapy yet. So advanced neuroendocrine carcinomas is, as you all know, it's a deadly, terrible disease. The outcomes of advanced NECs are very poor. First-line therapy has some activity, but typically with overall survival less than 12 months. So that was well shown in two recent studies from Asia comparing irinotecan platinum to cisplatin. Sorry, irinotecan and platinum to cisplatin and etoposide, and with overall survival less than or around 12 months. Therapy beyond first line has very little activity, I'll say. So PFS repeatedly shown in retrospective studies to be 2 to 3 months, and indeed the NET-02 study of Nellary with 5FU showed PFS of 3 months, overall survival of 9 months, and the just published PRODIGE 41 Bevanek, Lancet Oncology last week, PFS of 3.6 months on average, overall survival in second line of less than 9 months. So we desperately need better treatments there. So what's going on in terms of genomics of high-grade neuroendocrine carcinoma? So the main pathway is really the TP53 and RB1, and typically seen in lung and small cell carcinoma of the lung, but also in other high-grade neuroendocrine carcinomas. But then we have all these other genes that are mutated. For example, in pancreas, we see KRAS mutations. In colorectal, we see APC, BRAF, and other mutations. And this has all been studied, and we know that extrapulmonary neuroendocrine carcinomas are not small cell lung cancer. And why should we necessarily treat them as small cell lung cancer? So this is one of my favorite unpublished ASCO abstract from Dr. Bergsland from UCSF, I think using foundation data. Look at the small cell lung cancer here. Almost all of them are TP53, and most of them are RB1 mutated. And then there's a smattering of other mutations. Compare that to a G3 pancreatic neuroendocrine carcinoma, totally different profile. So here we see CDK and 2A and 2B mutations, and obviously ATRX, or not ATRX, but DAX mutations, and MEN1. Probably indicates an evolution from a lower grade pancreatic NET to a higher grade pancreatic NEC. What about the colorectal NECs? APC and KRAS mutations, isn't that the same we see in colorectal adenocarcinoma? Absolutely it is. Same thing with FBXW7, we see it in rectal cancer all the time. So it's definitely a different tumor. Why should we necessarily use cisplatin etoposide for those? Shouldn't we use something else? On a different note, this is Caris data, just looking at high-grade versus low-grade neuroendocrine neoplasms. A big difference is in P53, much more common in high-grade. KRAS, much more common in high grade, probably driven by pancreas and colon. And then we can see the same with APC, suggesting a pathogenic mutation in colorectal NECs. And then again, the immune markers are uncommonly positive PD-L1, even in high grade tumors. So this is probably one of my favorite paper from 2021. This is, I think, mostly the Nordic group have done Sorpi and his team in Norway and many, many others and all across Europe. Looking at the NECs versus NETs. So this is G3 NETs versus NECs. And as we can see, P53 mutations are very common in NECs, less so in the NETs. We can see KRAS mutations, very, very common in NEC, or not very common, 22% in NEC, but not really seen in the NETs. And these might potentially be targetable. I don't know how many of these are KRAS G12C, probably not many, if any. And then we have BRAF mutations. A substantial number of these are actually B600E mutations, and several case reports have shown that to be an effective therapy. So RB1 mutations, not targetable, and these are actually mostly deletions, not mutations. And then we have the pancreatic NET mutations there. In large cell versus small cell, we see BRAF mutations and KRAS mutations with some frequency. So a few important points about G3 NEN genomics. So G3 NETs are very different from G3 NECs, as we showed there. NECs of different anatomical locations have different genomic alterations. So should we consider colorectal-like therapy in colorectal NECs? So that hasn't really been shown yet. TMB tends to be low in NECs, 5 to 7 mutations on average, although some studies have shown more. And sometimes these mutations can be predictive of outcomes. So this is just one of my cases, refractory metastatic esophageal neuroendocrine carcinoma, had resection, adjuvant chemotherapy and radiotherapy, did well for a few years, had oligometastatic bone recurrence, which we spot welded with radiation, and then all of a sudden it all blew up. So he showed up to my clinic with extensive bone metastases in a wheelchair, ECOG PS3, but he really desperately wanted therapy. So we said, yes, we'll try Epi-Nivo, gave him Epi-Nivo. 3 months later, everything is gone. 24 months in, we have not seen any recurrence. He's coming in for staging next week. If he's still negative, I'm going to stop the Epi-Nivo and see what happens. So immunotherapy for NETs are not really that effective, certainly not for low-grade neuroendocrine tumors, but for the high-grade neuroendocrine carcinomas, there's probably about 15 to 20% response rate. Median PFS is short, as you can see below there, and typically less than 2 to 3 months, but there are definitely long-term responders. So how do we test for genomic alterations? We test tissue if possible. Liquid biopsies are also an option. This is a study from ESMO last year, 50 patients with advanced GI NECs, had tissue and plasma testing. 29% of them had mutations in liquid only, 36 in tissue only. And if you look at the potentially targetable mutations found in plasma of 52% of patients. What is targetable? That's actually obviously debatable. 18% of patients with potentially targetable mutations had only mutations in liquid biopsy. So one wonders if we should do both liquid and tissue. So to summarize, the high-grade neuroendocrine carcinomas, so extrapulmonary NECs are not small cell lung cancer. They have a very different genomic profile. The profile may predict outcomes, but hasn't really yet helped us select therapy, with the exception of those patients who have actionable alterations like BRAF, V600E. The immunotherapy efficacy markers are not very helpful. And then we should possibly consider liquid biopsy for all. I will say everyone needs sequencing, at least tissue sequencing, and I'm actually starting to do liquid and tissue for all of them now. So winding down into the last section here, so radiogenomics and selection of patients for systemic radiotherapy. So I'll go quick here, so we know that PRRT doesn't work for everyone, but there's really no good way of selecting who it works for. So we know that there are some radiogenomics profiles for external beam radiotherapy, but not for PRRT. So what I wanted to show here, and the whole concept about this, is that there are some patients who are more sensitive to toxicities than others, and we could possibly find those patients, possibly with chip analysis or something else, and we might select them for other treatments. There are some patients who receive PRRT who are not going to benefit at all, and we may be able to identify them with genomic testing and possibly direct them to other alternative therapies before we do the PRRT. So this is how it could look like in the future. We would start with the workup, do molecular profiling, possibly including a chip analysis, and then we would decide on a treatment plan, possibly adjust the doses and duration based on radiomics and possibly dosimetry. As for surveillance, we could use molecular surveillance, and if there is residual disease, be it visible residual disease or minimal residual disease, possibly consider consolidative therapy. So obviously this is not where we are right now, but this is where we might end up being. So the last couple of slides, I just wanted to mention the PPQ, or the NET test, as a predictor of PRRT efficacy. As we can see here, the patients with PPQ negative test, and as you know, this is a part of the NET test. Those who are PPQ negative have a much shorter progression-free survival than those who are PPQ positive. I think this is strong enough data to build the test into prospective clinical trials. So the last topic here is on the markers of hematologic toxicity and leukemia. So we know that we see leukemia in 2 to 3% of patients with PRRT. This very interesting paper from Roswell Park looked at 13 patients, 4 with serial sampling, and they found that there are chips or clonal hematopoiesis of indeterminate potential is fairly common in patients who undergo PRRT, and if you have it, you may have more prolonged cytopenia. And the thought is that with a PRRT, will kill the normal cell, not touch the existing chip cells, and there will be a clonal expansion of cells with mutations in genes like TP53 and TET2 and others that eventually will expand into leukemia. So we should possibly consider chip analysis for all patients. So one of the last slides here, so this was just at ESMO this year, or last year actually, 190 patients treated with PRRT, 4 MDS, 2 AML. So, and the patients who had MDS or AML were more likely to have received alkylating chemotherapy prior to the PRRT, and that's also been shown recently by the team at Moffitt. And also what we could see there, these are the patients with clonal mutations after PRRT. You can see expansion of certain clones, including TET2, TP53, that were not seen in the unmutated tumors. So I think I'll just stop here, and here are my conclusions, and thanks again for the opportunity to present.
And really, thank you very much for that wonderful lecture. Really, thank you very much. I think we have some time for questions. And we have a question and comment from Dr. Rickelman from Brazil. And she says here, great talk. She indicates that she has seen some cases turning into TMBH after CAPTEM and have used immunotherapy in these cases with good responses, but with a short-lived response. She's asking, what is your experience on that?
I had this discussion with a patient in the clinic yesterday. And so I've treated 2 patients with TMB, the highest TMB I've ever seen, 130 mmBs after temozolomide therapy, no response whatsoever with immunotherapy. We've had some informal discussion, including with Simran Singh, I think with Jen Chan and Diane Reedy, and we're all seeing the same, that these temozolomide-induced hypermutated states do not seem to respond to PD-1, PD-L1 immunotherapy. Whether they respond to Ipi-Nivo, I just don't know. I have not tried that yet, but very disappointing results.
See, we have a few more seconds. I think we have another question from Dr. Alejandro Roman. He says, great talk. Would suggest, Captain, before or after PRRT, according to your last slides, how do you sequence with PRRT?
Great question, super timely. This question is being now addressed in an alliance trial in pancreatic neuroendocrine tumors, just activated. I don't think they have any patients on yet. So this is led by my colleague at Mayo, Tim Hopday. Patients who progress after somatostatin analog therapy and kinase inhibitor therapy will be randomized to either PRRT or CAPTEM, and we encourage enrollment on that study wherever we can. How do I do this in practice? I just have this discussion with the patients. I tell them, based on data from Dr. Strasberg and his team and data from Australia, that the leukemia risk may be as high as 10%, but then I also tell them 10% over the next few years obviously is a high number, but some of these patients would actually never make it that far if we didn't give them this therapy. So you have to balance the benefits against the risks. As for sequencing, I don't know. It ends up being a very personal decision, sometimes actually driven by insurance coverage.
And really, thank you very much for the answer. And I would love to continue asking questions, but yes, we have to move to the next section. And really, thank you for everything and happy birthday to you in this wonderful day for Latin America.
Definitely find me on Twitter.
Thank you. So I'm going to give now the podium to Dr. Jennifer Chan and the panelists from Latin America. And they are going to discuss very much about the situation in Latin America. And really, thank you for being with us today. This is an opportunity for us to know more about who we are together.
Thank you, Dr. Jimenez, and good afternoon, everyone. My name is Dr. Jennifer Chan. I'm a medical oncologist at Dana-Farber Cancer Institute. I want to start first by saying this has been a really terrific meeting, and it is my pleasure to moderate our first panel discussion of the afternoon, which, as Dr. Jimenez said, will focus on the delivery of care to NET patients across Latin America. I'd like to welcome back our speakers from the morning, Dr. Juan Manuel O'Connor from Argentina, Dr. Daniel Bolzico from Brazil, Dr. Paula Jimenez Vasquez from Colombia, and Dr. Alan Burguete Torres from Mexico. I'd like to ask each of you to give a brief description of the climate for NET care in your respective areas, and I'll start first with Dr. O'Connor.
Okay, thank you very much, Dr. Chan, for give us the opportunity for sharing how it is experienced, at least in different countries. So I think that first of all, I think that's quite different situations in different countries. Particularly in the case of Argentina, we have a working group that was created in 2005. So there are many specialties involved. Difficult to include all specialties in one center. So I think that it's difficult to move to the NANETS model in terms of some reference centers. But I think that it's a network in our country. So they have some public and also private system. So we have the possibility to work all together in this case. So, but unfortunately, there's some inequity. That's the problem in terms of the access, for example. But I try to give at least in terms of some, for example, the committee for all people from outside of from Buenos Aires, for example. Just this is a quick, in a brief, our clinical situation, or at least how to work or how to try to work and improve the taking care for NET patients in our country.
Great. Thank you so much for sharing that information. I'll move to our next panelist, Dr. Bolzico.
Well, hi, everybody. I have just a couple of slides. Can I share with you in order to illustrate how the situation here in Brazil?
Of course, thanks.
Okay. Can you see it?
Yes.
Okay. Well, we have most of our population concentrated in the southeast region of Brazil. And here we have a mixed health system. 80% of the population depends exclusively on the public health system. And we have about 1/4 of the population that have some kind of private health insurance. In both cases, we have most high complexity centers concentrated in the southeast region. In terms of oncology, when we talk about the public health system, we have 44 centers of high complexity in oncology that they are the CACONs, and the headquarters is where I work, the Brazilian National Cancer Institute. But we also have some units, the 257 units of high complexity in oncology, the UNACONs. Some of them have radiotherapy, but most of them, they don't. And in terms of the private medicine, I can say that we have private centers of excellence in major cities. Just as Juan just said, we have a lot of inequity here in Brazil. For example, in terms of diagnosis, the public system doesn't have 5-HIA available in all centers. They remain still on regular CT, MRI, and very sporadic centers. We have the endoscopic ultrasound. Ultrascan is still the image of choice when we talk about functional imaging, but it's not available also in all centers. And in terms of pathology, Ki67 and specific markers are only available in central centers. It's all the opposite when we talk about the private medicine. We have all of this in very good quality cancer centers. And in terms of therapy, it occurs the same. Surgery, radiotherapy, and conventional chemotherapy is the mainstream in most public system centers, except, for example, at my center, which is the largest one, is the headquarters, where we have somatostatin analogs, everolimus, and multikinase inhibitors, PRRT, but it's not a reality in most centers from the public system. And when we talk about the public system, we have it all. So it's a huge gap between there's a huge gap between the public system and the private system. And it leads to differences in access. For example, when we talk about somatostatin analogs, 80% of the oncologists have the access for this medication when we talk about a private system, but only 20% of physicians can prescribe it when we talk about the public system. Well, that's it. I'll stop sharing this.
Great. Thanks so much for sharing all that information and those perspectives. I'll move to our next panelist, Dr. Paula Jimenez Vasquez.
Okay. First of all, there is a statistical report at the Colombian level to obtain the registration of the first 10 pathologies in cancer in the Colombian population. So we don't have a record of incidence or prevalence of neuroendocrine tumors, taking into account that it is not a part of the 10 of the most important oncological pathologies. In addition, there are mistakes in the coding of these pathologies. For example, In the analysis of gastrointestinal tumors, there may be gastroenteropancreatic neuroendocrine tumors, and the analysis of thoracic tumors, there may be neuroendocrine tumors not included in statistics. We have to improve our characterization of neuroendocrine tumors to try to improve our work in this scenario. But in Colombia, we have at least 8 multidisciplinary groups working actively in the adequate diagnosis and treatment of neuroendocrine tumors, located in 5 of the largest cities. But keeping in mind the volume of the population, more of these groups are needed in our country. And for example, about the medicines, all kinds of medicines are available in Colombia, but that can be used for neuroendocrine tumor treatment. But unfortunately, some of them don't have the approval by regulatory agency, and the prescription of these medicines has obstacles by our healthcare system, arising delays to start these treatments. But for example, I am thinking is a good option in Colombia. We have experience in the use of therapies such as lutein. However, only a few institutions have them, but for example, in the National Cancer Institute, they have a very good experience of its use with some descriptive publication in specific populations. In Colombia, it is possible to showcase before to the HMOs in case-by-case basis and as many times as applicable or a legal action. But for example, we have wide experience of performing surgical and interventional procedures in all areas of neuroendocrine tumors. And for the proper diagnosis of neuroendocrine tumors, we have trained pathologists. And for this reason, we notice an increase in the incidence of the disease.
Thanks so much. I'll move to our final panelist, Dr. Bergetti.
Hi, everyone. So we have, as Latin Americans, we share some of the problems in terms of, first of all, epidemiology. We do not have a cancer registry, a nationwide cancer registry in Mexico. Some efforts have been done towards this thing, but no, it has not been completed yet. So we actually don't know the true incidence of these tumors. And my suspicion is that this cancer registry will not be so specific to say that neuroendocrine tumors will be like a separate entity. Okay, so probably all these diagnoses will be within these cancers of the esophagus, of the pancreas, etc. So it's going to be hard to know the true incidence of our patients. Also, the majority of our patients are in the public health system, which is very limited, and mostly the cancer care concentrates on secondary and tertiary hospitals in our country, which are really scarce. So in terms of epidemiology. In terms of diagnosis, I would say that 90% of the time we receive patients with neuroendocrine tumors, the pathology report says carcinoid tumor, and that's it. We have no more information about it. So very few centers in the public health system have a specialized pathologist or even access to immunohistochemistries to correctly classify these tumors. In terms of therapy of management, I would say here in Mexico, all cancers are treated by a specialty that's called surgical oncology, which is not, it's different than in the US, where the colon cancer patients are treated by the colorectal surgeon. Here in Mexico, all cancers are treated by cancer surgeons. So this specialty is really scarce all over the country. Also, liver surgeons for local therapies or metastasectomy are also scarce. And the concept of multidisciplinary team meetings are actually very, very scarce also in the public system and in the private system. So in terms of access to drugs, I would say that octreotide it's fairly accessible, I would say, for all patients. Unfortunately, as I said, all the cancer care is done in tertiary hospitals, so it's not readily available for everyone. In terms of chemotherapy, CAPTEM or cisplatin etoposide, I think I would say that it is accessible for the majority of our patients. And in the complete opposite happens in the private system. In the private system, we have access to all drugs. We have access to all diagnostic armamentarium, I would say, and also for specific therapies such as PRRT, which is available, I would say, in the 3 major cities in the country, but not everywhere else. And lastly, I would like to discuss about the access to clinical trials, because this is also a problem for many of our patients in Latin America, that very often we are included in the design of clinical trials, but only for phase 3 trials for the most I would say popular malignancies such as breast cancer, lung cancer, GU, and only for expansion cohorts. So we are not, we do not have readily available clinical trials for patients with rare diseases. So, so that will be like a call for action, but this comes in the next session. But to include in this part of the diversity, included patients from all over Latin America to clinical trials. And so that will be an overview of the NET care in Mexico.
Great, thanks so much. If there are any questions for the audience, please use the Q&A function. I wanted to start also, it was interesting to hear everybody's perspectives. It sounds like there are some similar issues and perhaps challenges. And also this issue of access. I think we kind of across the world also face this issue of limited access to trials and to certain therapies. I'm curious if there are networks or collaborations that are beginning to develop to help facilitate that or to increase access, for instance, with perhaps less urban centers or oncologists routinely reaching out to whether it be like remote or you know, consultative type relationships that might help with the care of NET patients at any of your institutions or countries.
Yes, well, in Mexico, there's an association. It's a patient-led association. The aim is only so far has been to increase awareness of this disease and probably and Dr. Del Rivero has given a couple of talks for this association, the NETS Association of Patients in Mexico, and but it is currently developing. I would say it has, I think, a couple of years been going on, but to my knowledge, that's the only one that exists, at least in Mexico.
Yes, Jennifer, in the same line as Alan said, there are some association also in Argentina for the GIS and NET, because there are some similar behavior at some point, and there are some, I would say, patients that increase the awareness of the disease, and also some group of physicians, but very low number in general. I think that it's probably it's an unmet need to increase and probably to growing up in this situation, to working with some patients association. So, but there is some association also in our country.
Thanks.
Well, here in Brazil, we have some contact with associations from patients from rare diseases. and in this case, NET patients are involved. But the main issue is that the access must be made only by the primary care. So a big issue is that we have to make a big effort in order to aware primary physicians, so patients can reach out for the big centers in this sense.
Great, thanks. Dr. Jimenez?
Yes, in Colombia, we did a very interesting work about education of the population. In 2009, we did education sessions, but because of the pandemic and the lack of information of this pathology, the sessions have decreased. And unfortunately, we have a small support and sponsorship by the pharmaceutical industry in Colombia. That is another factor contributing to this decrease. But for example, in 2023, we will resume the multidisciplinary group work, covering the specialties required for the formation in suspicion, diagnosis, initial approach, and early remission of patients throughout the Colombian territory, and it could be expanded in Latin America as applicable.
Great. Thanks so much. It's been great to hear everybody's insight. It sounds like there is a lot of progress, a lot of room for education and increased access and collaboration. So I want to thank all of you for sharing that information about the NET care in your countries. And I'll invite Dr. Del Rivera to lead off the next session, which I think what we discuss leads very nicely into perspectives for collaborative work in the future. Thanks.
Thank you so much, Dr. Chan. And now on to our last session of the day. And I have to say, this has been a very wonderful meeting, and I'm very honored to be part of this. And thank you so much for everyone who participated today. So in addition to Dr. Juan Manuel O'Connor, Dr. Daniel Bulsica, Dr. Paola Jimenez Vasquez, and Dr. Alan Bruqueta Torres, I would like to invite back Dr. Camilo Jimenez and Dr. Nina Villavergia. I would also like to introduce Dr. Sari Maragosa Salgado. She's an assistant member in the Department of the Head and Neck Endocrine Oncology at Moffitt Cancer Center, and she was also involved in the development of this program. We already discussed earlier some of the difficulties in terms of clinical care that happen in South America. And one of the questions that I have to each one of you is what is the barriers that you have in terms of research and neuroendocrine tumor research. And the reason why I'm asking that is because in order for us to advance the science that then will translate into the care of the patients, clinical care of the patients in terms of the guidelines, we need to base that on the research that we're doing in neuroendocrine tumors. Based on that, maybe I can just start with Dr. O'Connor. What has been the barriers that you have experienced in neuroendocrine tumor research?
Well, thanks, Yadira, for the introduction. And I think that we have some barriers that maybe the good news is that I can identify some barrier for taking care for the patient. I think that I would like to point it out 2 or 3 points. One of these is that I mentioned before the lack of funding for some research in our country. So not only for clinical trials by the pharma, for example, and even for some initiative investigator research. That is a very, at least I think that it's important. As my dear friend, Dr. Richman said, we have many ideas, but we don't have money. And I think that the other part of this is why not try to collaborate between different countries in Latin America, because of the huge population, and also there are many people interested in growing up more in terms of information, improvement of taking care for our patients. I think that the key point is how to improve the taking care and also reduce the inequity for our patients, not only in neuroendocrine tumor, but more probably more even in cancer in general. But our message here is in terms of the neuroendocrine tumor. And the other part probably is maybe how to create this kind of collaboration. I think that is a kickoff from, fortunately, from the United States and the NANETS Society. A big thanks for all again. But I think that we need to move forward in order to create some collaboration in terms of the taking care, how to create more broadly consensus in terms of the treatment, but the consensus not only as a copy paste, because this is I think that it's not probably the better way to go forward. More even adapted some very nice guidelines from the American, from the NANETS, from different international societies. So I think that at least I have, or I identified 2 or 3 main points to probably go forward for the future in order to collaborate with in this field in neuroendocrine tumor data. Thanks.
Thank you so much, Dr. Connor. I think you mentioned something very important, that is that we develop guidelines, and with those guidelines are based on the availability of data that we have and availability of resources that we have in the United States. That said, it seems that in South America may not be the same. So I think that there is definitely a gap there, and something that we should definitely help and form more collaborative efforts to help and have availability of what the resources in terms of the management of neuroendocrine tumors. With that, Dr. Bulsico, what has been the barriers that you experience in terms of neuroendocrine tumor research?
Well, I totally agree with Juan Manuel. I guess that funding is the main issue. We have a big population, a continental country, and I think that we have so much to offer in terms of diversity and the multi-ethnic pattern from our population inside the whole Latin America. And we also share some peculiarities in terms of economic situation. So most of the guidelines there and cost-effective studies that are made are based on high-income countries. So I guess that we need some cost-effective studies in terms of therapy that should be in line with the reality in Latin America, and therefore we can use this in order to search for public assistance in order to reach out the best therapy that could be offered to as much as people we can. This health public system is something that we should value, but we need to prepare it for our economic reality, of course.
Thank you so much, Dr. Bulsico. And I mean, I completely agree with you, and you touched on a very important aspect, which is diversity. And that's something that we should definitely include in our clinical trials. I know here in the United States, one of the efforts is to include diversity in every clinical trials. And it's true. I mean, we're trying to understand as well what is the effect of certain drugs and many diverse groups. And thank you so much for bringing that. And that will be something, of course, that we should be able to work together as a collaborative effort. Dr. Jimenez Vasquez?
Yes. In our country, research has been developed in different areas. In the 76 centers enabled to do this. 16 of them do research on oncology, both with own resources, which is more difficult, and with the pharmaceutical industry. Unfortunately, the interest in neuroendocrine tumors is based primarily on own ideas, and its sponsorship is hard to get. I am convinced that people working in this pathology are seriously interested in participating in international studies, which could be included in Latin American countries, either through, I don't know, NANETS or other organizations, that I think is a very good opportunity to try to get this in Colombia for neuroendocrine tumors.
Yes, Dr. Jimenez. Yes, Dr. Jimenez, thank you so much for bringing that up. And yes, I think we agree and about where the limitations are, and that will be something that working as against collaborative efforts, forming more of groups that can work together will definitely help. And that's something that we, by doing these webinars and working together, hopefully we can also, that will be our goal as well, to enhance more advocacy for patients in need. And last but not least, Dr. Burguete Torres.
Thank you. So I would say that one of the first barriers I have found is that it is really difficult to find patients because all patients are distributed in the public health system, and there is no even I would dare to say that the coding of the diseases is actually outdated. So neuroendocrine tumors are not included in the past coding systems. So it is, the first thing is it is hard to find patients for doing research. The second problem I would say is that funding is universally is a problem, I would say, for Latin America. So you can have an idea. Just this year, the budget for science in Mexico was cut more than half. So we are currently investing only 0.1% of the GDP of Mexico in science, and this has to be distributed amongst all the specialties of science. So as you would imagine, there is very little space and resources for medical therapy, for medical research, and for specifically for rare diseases. So this the funding of the of all the research that has been done is mostly by universities with their own budget, who spend their budget into I don't know, a particular research. So that's about it for our situation in Mexico.
Thank you so much, Dr. Burguete, and we understand. There is a comment also from Dr. Pimienta that said that Brazil and Argentina has quite a few studies published in nice journals, and collaboration is possible, but it takes a lot of personal efforts. And that's something that, you know, maybe something to discuss here. But that said, I just wanted to bring Dr. Acosta Salgado, just to, based on what you have heard today, what are your thoughts and what could be something that you will, possible solutions of the situations that we have heard?
Thank you, Dr. De Rivero. First of all, I need to congratulate all the panelists here. They have done an amazing job today and have really shown their expertise and heart into advocating for neuroendocrine tumor patients. As an oncologic endocrinologist, I am actually originally from the Caribbean, from Puerto Rico, and can relate to a lot of the health disparities that you're mentioning, even practicing in the mainland US at areas that have high density of Hispanic populations. And I agree that we need to be stronger in advocating to more representation in clinical trials. I think formalizing alliances that are multinational, that can actually result in advocacy and changing of public health policy, bringing into the reality that our patients with neuroendocrine tumors and rare endocrine tumors, that I do hope that there's even more webinars that that include some of the tumors that that I know Dr. Jimenez and myself work with, like FIOS and PARAS. joining that force, but I think we also should align the mission of advocacy and the science of research to also medical education, starting at the level of early career members that we can identify in our respective countries, as well as establishing peer mentorship relationships, because I think it's been clearly demonstrated today that we can all learn from the different experiences, and perhaps starting the research mission, creating multinational databases that we can come together and publish the real world experience of our Hispanic patients and show that that we are here, we are present, because together we are definitely stronger, and we're here at the end of the day to give voice to our patients.
Thank you so much for that, Dr. Acosta. Dr. Jimenez, anything that you would like to add?
Yes, and really thank you all for the comments, for the participation in this event. This is, again, the beginning of a relationship that is going to be perennial, that is going to be long-lasting, a relationship in which we are going to learn from each other who we are, and a relationship that we will make very productive. We'll work together, we'll grow together. We have the support of our leadership, and I can tell you, all the comments I have heard, all the ideas you have provided, the presentations that were given this morning and early afternoon in your different countries, clearly indicate, number one, the passion that you have for this, number two, the interest and the necessity that exists in Latin America for all these conditions. Number three, the fact that you have really created knowledge, have grown together despite of several difficulties, and that's priceless because you've been able to move through the very difficult pathways, finding solutions for the problems that you have. And of course, the fact that, yes, we need to work together to make everything possible for you as well there, removing the differences, but recognizing that we are different at the same time. So that, I think, is quite important here. And all the information that you have provided is information that Sari Maragosto, Jaidira del Rivero, and myself, with our presence, we are going to share, of course, with our different committees, and soon you are going to hear from us on what we are going to do in order to make this to succeed even further, because we need to learn from you. Your patients are likely different from the ones that we have in the US and Canada. We can have clinical trials that may go to your countries as well, and likely will learn more information that we were not aware before. So yes, this is an opportunity to really work together. So really thank you for this. And of course, this information, I will take it. I am just the clerk in this session, but this information will be taken to the Committee of Diversity and Inclusion and Membership at the NANETS, and of course to other committees within our society.
Thank you so much, Dr. Jimenez, for that. So I have other comments here. So one of the problems in Latin America, private investment in science is almost unheard of. And any comment about that? Maybe Dr. O'Connor, do you want to comment about that?
Sorry, Yadira, what is the issue? I think in terms of...
So the
private.
Yeah, private investment in science. Private investment in science is almost unheard of.
Yeah, I agree. I think that it's a difficulties in terms of the at this point. But I think I try to view in more enthusiastic view of the situation, and I think that we had to innovate some. Just to solve the problem, but I agree that it's probably a problem for I think that in many countries in Latin America. The most important is to generate some resources. It is not easy, but I think that if we are all in the same in the same with some similar ideas, probably it is better go forward. But Yes, this is my comment on that.
Yeah, great. Anybody want to comment anything else? I do have one last question that I want to ask, but I was just wondering if anyone else has any comment to add.
I think we should I think we should have some fronts, some direction. Maybe we can maintain these regular discussion group, and we can divide into some issues. For example, funding, pathology, epidemiology, and we can maybe have some ideas of how we can work together in terms of pathology education, or population awareness, or private practice continuous education in terms of recognition of disease. And we can do it distantly by a red cap or any other. And also we all want to be seen by the clinical trials. We need that, and our patients need that, as just Alan said.
Yeah. Dr. Jimenez, you wanted to say something?
Yes, I think in Colombia is very difficult, and most of the time we need a sponsorship by the pharmaceutical industry, but today it's so hard to get this sponsorship. For this reason, we have to try to use owner resources to try to do research in Colombia, but it's very difficult to do with private resources.
And a follow-up question on that is about clinical trials, because my understanding is that in South America, there are very, very few. What are the barriers on the institution where you are to open a clinical study or clinical trial, a treatment trial? Because, I mean, we have multi-institutional clinical trials, and I was just wondering in South America, what is the barriers that you experience in opening a study at your center? Maybe
here in Mexico, one of the main barriers is that we're sometimes left at the very last as a population, because sometimes when we receive a clinical trial effectability, they're looking for, because they didn't accrue enough patients in the US or in other important countries, and so they're looking for more patients to meet the accrual quota. So very often they this kind of spots for clinical trials are very competitive. So it depends on how readily available is your ethics committee, for example. And the return time of the ethics committee sometimes is very long. Sometimes they meet once a month, once every 2 months. And sometimes these clinical trials need faster response times. So I think that it will be very important for us in Latin America that when the people who are designing the clinical trials have a specific amount of patients from Latin America to be considered, in order to be considered at first with the initial design, and not just to try to accrue more patients at the very last moment.
Let me just a quick comment about this, Yadira. I think that it's for this purpose, it is better to create a group in different countries. I think that it's better because it's a rare disease, so it's difficult to go for just 1 or 2 institutions. So I think that probably this is just to fill in the gap of, and also the most important is the interest to include some countries in Latin America. But I think that is why create in local team, local and regional team, it is better in order to probably generate more interest by the pharma in order to include our countries.
Yeah. Anybody else has any comment? Dr. Jimenez, Dr. Agosto?
I
What
echo.
I see is that you have everything to do the trial successfully. We have to make that possible.
Right.
It seems that you have everything. Let's say it's obvious. Your presentations this morning were absolutely fantastic. The amount of knowledge that you generated this morning was phenomenal. And again, the passion, and you have the technology, you have the patients, you have everything. So yes, we'll find ways to work on this.
Yes.
I think as diversity advocates, it would have to be part of our mission, as much as passionate as we are about our patients, about bringing this forward.
Yeah, great. Thank you so much. This ends our session and our day. This has been a wonderful day. So in behalf of the North American Neuroendocrine Tumor Society, the Diversity Membership Committee, as well as Education Committee, of course, the NANETS team, Ms. Claire and Ms. Simons as well, and of course, the sponsors that were the thanks to them make this webinar possible. I think this was an amazing day. I think this is the beginning of a wonderful collaboration. Certainly, that's something that we wanted to include all countries of South America. It was wonderful representations, not only from Mexico, Brazil, Argentina, Colombia, but I think one of the efforts is to also include other countries from South America. I think that together we can definitely make a difference in our patients' life, and we can definitely make a difference in the management of neuroendocrine tumors. And with that, I thank you all for being with us today. And until next time, hasta la vista. Muchas gracias.
Thank you very much. See you next.
Thank you.
Hasta